Okay, everybody settle down. Very good, very good. Okay, good morning. And thank you to everybody for coming out on time. We are running late as usual. Welcome to the second day of the inaugural Palliative Care Conference. We are a much smaller crowd today, small and select. So we'll just crack on with proceedings. So the agenda of today is we have two presentations this morning. We have Dr. Danila doing the first plenary session, followed by Avtar's presentation. We'll have a break, and then we'll go straight into the workshops. We have 4 workshops planned. We have quite a lot of time allocated for each workshop. If we finish earlier, that's just a bonus. So it is in everyone's interest to be proactive. So we'll crack on. So first presentation for today. Very, very happy to introduce Danila Zuvetti. She's an international expert in narrative medicine with a focus on palliative care. She's the founder of the NAMPAC model, the only registered narrative medicine model specifically designed for palliative and chronic care. As the head of the Caring Community Project in Lodi, she leads initiatives that integrate community support with healthcare. She's a seasoned trainer and facilitator for the Italian Society of Narrative Medicine, and she's been advocating for palliative care for over a decade. She actively works with patients, implementing a specialized narrative medicine approach that enhances the multidisciplinary care team. If you're not already on LinkedIn, I suggest that you join LinkedIn and connect with Danila. This is how we connected. And I've always wanted to learn more about narrative medicine, and just by chance, we connected over LinkedIn. So very, very nice and lovely to welcome you. This is Stefano sitting just over, standing. So Stefano is fluent in English and Italian, and if Danila feels the need, she'll just be getting Stefano on stage to translate, depending.
Thank you. Good morning to this incredible expert and simulating audience. I'm very pleased to be here with you and to share my knowledge with you and to listen these stimulating and interesting speeches. Thank you, Dr. Neil, for this opportunity. My name is Danila Zuvetti. I am the founder of the NAMPAC model, Narrative Medicine in Palliative Care. This model has been specifically thought to match with those integrated actions related to palliative care, oncology, and chronic illness. In the course of my growing up as a specialist, I have developed a net of collaborations with different organizations, private and public institutions, whose goal is to improve their approach to patients who suffer from oncological and chronic illness or are following a palliative care path. Thanks to this approach, up to now, I have had the opportunity to work with the first-rate caregivers and experts all involved in this branch of research. As a professional trainer, at present, I'm in charge in the caring compassionate community in Lodi, my town in Italy, situated what we can define Greater Milan. I'm proud to telling you that is one of the few examples in Italy. Every time I have to explain what narrative medicine is, I say that it is like a clearing, a marvelous point of light surrounded by darkness, and that in order to see the light, you must know how to face the darkness. Indeed, narrative medicine can help to achieve of this through narration. As everybody knows, palliative care now includes both holistic and interprofessional approaches, emphasizing at the same time the necessity to give personalized responses to physical, psychosocial, and spiritual needs. In fact, this is the reason why narrative medicine has become extremely important to improve patients and their families' life quality. As Rita Charon wrote, narrative medicine is a practice enabling healthcare providers to recognize, interpret, and respond to the stories of illness by supporting better communication, fostering collaboration, and offering more ethical care. In 2015, due to my working in chronic care and palliative settings, I did realize that both my patients and their families felt a very strong narrative need, which had to be necessarily different from what any psychological support or spiritual needs or even voluntary activities can satisfy. Therefore, thanks to my listening to what my patient told me, and thanks to my previous care experience in a structured, yet in a totally free way of being carried out, it's possible for me to elaborate a new and well-structured method, the NAMPAC model. Both narrative medicine and palliative care are two different disciplines, even they have a lot of similarities. The NAMPAC model is able to join all these similarities, which can be summarized this way. Holistic and personalized care. It is important to underline that the NAMPAC method is able to support an individual as a whole being because it approaches patients always referring to the physical, psychological, social, and spiritual dimension of their illnesses. Proactive and dynamic approach. The advantage to this approach is that it can adapt itself to any possible changing conditions, so that the healthcare personnel are always updated as regards the complexity of chronic and terminal illnesses. Narrative integration. Last but not least, we can say that this model works by using the well-known storytelling practice, narrative medicine practice, in order to better both the patient-doctor relation and their communication, therefore promoting a shared understanding of what an illness journey is and means the final result is to inform consent easier. Working with narrative medicine in palliative care and oncology means working with complexity. It's not just the collection of history. It's not a history. This is very important. Briefly, we can say that narrative medicine focuses on every single word and those words which can really be considered useful at very moment when the specific patient feels the specific need, which can be satisfied just with the specific word. If words are important, the yours is even more important because you should know where to place them. The narration of our body, as our body is subject to continuous change. It is absolutely important to have the capacity to narrate at the very moment it is communicating. Once more, we realize that the principal concept of narrative medicine is the individual. The possibility to face and better those conflicts that in a palliative care path might happen among specialists, their patients, and their families, patients' families. The capacity to discuss in an efficacious way critical matters, situations, or issues. To help patients to narrate the rap to the unspoken or intimate needs. To help a patient to become fully aware of his or herself. The most significant aspect of NAMPAC model is that it can be employed in various situations. For example, acute care, chronic care, home care, telemedicine. It consists of different structure phases, which include narrative interviews, feedback sessions, and a symptom assessment, which refers to the IPOS, Integrated Palliative Outcome Scale, which is a validation tool that allows clinicians to measure the effectiveness of the narrative approach, while it ensures that the patient's necessities are systematically considered. Therefore, we can absolutely conclude that IPOS is to be considered considered as an integral part of NAMPAC model, which can fully satisfy multiple purposes. For example, it can simulate patients to narrate their general personal trouble and difficulties to specific experts, or it can be useful for estimating the effectiveness of the narrative medicine pathway itself by comparing the acquired results started from the second IPOS administration, 7 days after the very first. These ways, results will be related to the different symptoms or aspects emerge during the narrative interview. Finally, the above-mentioned method enables the narrative medicine expert to share the final scientific conclusion with the whole teams, thus providing any additional monitoring of the patient overall situation. In order to give a brief and clear explanation of additional value the narrative medicine in palliative care can give, it is enough to say that it focuses on any possible patient's narrative needs, which can be of various kinds, clinical, psychological, spiritual, or even care-related. The NAMPAC model integrates narrative medicine into the care pathway itself, promoting at the same time interdisciplinary coordination while ensuring that each patient's personal story is listened to and fully understood. Indeed, thanks to this narrative method, a better overall care approach for both the patient and their family can be obtained. Please, we will follow me. Looking at the image on the screen, you can see two different moments of two my patients who followed a narrative medicine path according to the NAMPAC model. In the first image, my patient was at home. Unluckily, up the moment, he had never expressed his will, but thanks to my model, thanks to narrative medicine, he was able to narrate his still hidden desire to play the guitar, addressing his performance as a gift for his wife before dying. And so he did. In the second image, instead, we can see my second patient in hospice. Before my intervention, she could not and did not want to leave her room. But then, just thanks to the narrative medicine path, she could narrate the reason why she had decided never to leave her room. This way, she could become a really active presence in the hospice. In the last image, we can see another patient whose pathology, an advanced stadium of cancer, had provoked in him such embarrassment and fear that he had decided to live isolated in his room. For 3 months, he had lived locked up in his room. Of course, I had to work with him for a long and very intense period, following the NAMPAC model procedure. To conclude this story, I would like to read you what he said just before dying. The final result was that he could live the end of his life with absolutely dignity.
Who would have thought? Who could have imagined it? Yet it is happening. The long lethargy and darkness that had clouded my life for 3 months seemed to have lifted. I never thought, never believed, that narrative medicine could awaken this in me. It feels like waking up in the morning and finally seeing that the sky is clear, realizing I am more than just this ugly, disgusting evil that has scarred my face. I don't want to fill my life with empty words, but with words full of life. This long journey in narrative medicine, a discipline I knew nothing about before my illness, is giving me the chance to rediscover myself, to reclaim my dignity and my life. I hadn't left the room, but Dr. Danila was patient enough not to give up on me, and today I was invited to a party in the ward. For me, it was the first time I had left the room in 3 months. It was a beautiful party, one that is hard to forget. It became a part of me. If the beauty of this celebration, the joy, the sense of companionship, and the absence of shame can be compared to heaven, then it's truly worth hoping for heaven, for everyone to reach it. Today, I am happy.
Thank you, Stefano. The last narration belongs to someone who narrates her physical and spiritual pain. And the end of her path with me, this patient was able to narrate her pain through narrative medicine, which is clearly different from the psychological approach.
Pain is sometimes difficult and can be overwhelming, making it hard to manage. Today there are drugs and palliative care, but it is always lurking. Most of the time, it takes away your independence, and on a human level, that makes it unbearable. Thanks to science and medicine, pain can be alleviated today, allowing you to live as pain-free a life as possible. Physical pain prevents you from thinking and becomes mental pain too, a kind of total or global pain. Pain is difficult to manage and even to define. It depends on the kind of pain. I have different types: tumor pain and neuropathic pain. Pain is a form of suffering that must be managed. I feel my body different depending on whether I feel good or bad. When I'm feeling unwell, I don't even think it's my body, and I live in fear of saying that bad period is coming, and then when it passes, I tell myself it's over. I hope that those who read these pages and may find themselves in my situation can learn to manage the pain and accept the pain of having a tumor, meaning becoming aware that this pain comes from the illness. For me, it is important to be aware of everything, because if you don't know, you can't help yourself. But if you know, you can seek help in any way possible. Being aware also helps you draw closer to your loved ones, to God, and to live this life more gently.
This is very important. NAMPAC model in caring community in Italy introduce for the first time a model that integrates narrative medicine with the philosophy of palliative care at a community level. The key objectives are to address sensitive topics such as death, fragility, and pain across all age groups, create an empathetic and supportive care environment that involves patients, families, institutions, and associations, and promote communication between professionals and the community. The outcomes include improved coordination between healthcare professionals and local institutions, increased awareness and sensitivity around end-life issues, and the development of an active, supportive community network, enhancing the overall quality of life for everyone. The narrative medicine in palliative care has been thought to answer healthcare professional needs in different situations and/or places, such as hospitals, hospice, and community care location. It is obvious that also physicians, nurses, social workers, and psychologists are involved in the care of those patients who suffer from life-limiting illnesses. All of them aim at improving their skills in narrative medicine, together with the desire to ensure that their palliative care practices are comprehensive and responsive to their patient different needs. Implementing the NAMPAC model means to be involved in a structured training which goes beyond a basic knowledge of narrative medicine and palliative care. Namely, what the training emphasizes is the correlation between narrative medicine and palliative care principles, carried out by a multidisciplinary team, as the training itself should cover medical, psychological, and spiritual aspects, so that it could help professionals to integrate this principle in their common care practice. It is absolutely sure that at the end of the training, a participant will get a deeper understanding both of narrative medicine and of all those necessary practical skills which employs it principle effectively. Briefly, the trained professionals will be able to offer a compassionate and professional care, which covers the whole spectrum of their patients' needs, promoting an overall patient's care. Before concluding, I would like to show you this video, which was realized by an Arabian patient. The protagonist and her story, told in Arabic, a translation into English in a slide, are my way to say thank you to this wonderful country which has welcomed me.
السلام عليكم، صباح الخير. أنا معناها بعالج معناها مع إنسانة طيبة، وأنا لقيت روحي كتير معناها في الصحة، معناها في العلاج من معناها الطب السردي. هي إنسانة طيبة، والطب اللي هي بتعالج بيه أنا ماشية معايا في حياتي، ولقيت نفسي مرتاحة مدة عام، وتحسنت كتير، وكنت معناها يعني حتى مورالي طايح، وصارت لي مشاكل في حياتي سواء في الصحة الطبية، وإلا في معناها مشكلة عائلية، فقدت بنتي. ولقيت أنا الإنسانة مع هذه في الصحة الطبية، لقيت معاها كثير حاجات اللي معناها هزولي مورالي وخرجوني من الحياة. كما حكيت وقلت لكم، هي الوحيدة اللي أعطتني الضحكة في حياتي، وخرجتني من الأزمة اللي أنا فيها. ما كنتش نتصور معناها الطب العلاجي هذايا يكون معناها معناها كما نقولوا حاجة مهمة كتير. ولهذا أنا إنسانة مستعرفة. هما فيه كتير معناها من الناس اللي هي تواجه فيهم، كتير هي قاعدة تروح معناها الإنسان تخرين، لكن هما معناها عندهم اللغة لغة أخرى مش كيفي أنا عربية ومن تونس، وأنا معناها نجم نعمل فيديو ونقول لكم راي حاجة ما هيش موجودة. فريمون أنا أول مرة جربتها، وأول مرة معناها ماذا بيا مدامني حية نواصل فيها حاجة ياسر معناها مهمة كتير. فهمت؟ حاجة مهمة. وقلكم إن شاء الله تسمعوا اللي قلته، وما عندي علاش باش نخبي ولا حاجة. ولهذا نقولكم السلام عليكم، وإن شاء الله معناها تاخذوا كلامي، وربي إن شاء الله يوفقكم وتسمعوا اللي قلته وتصدقوه. والسلام.
In conclusion, we can say that the NAMPAC model and narrative medicine in palliative care complements narrative medicine and traditional palliative care. That is why it is important a mere replacement for existing professional roles. On the contrary, it is a method whose aim is to enrich the psychologist or spiritual care provider, to enrich the interdisciplinary care provided to patients. As a consequence, the benefits obtained following is the method are a substantial improvement of patients' life quality, thanks to to structured narrative pathway, while supporting patients' families by helping them to express their own experience and emotions. This is what I myself create with Eduardo Bruera, narrative pain, or the distress that arises when individuals cannot express their emotion and experience efficaciously. Moreover, the above-mentioned model support care teams' well-being by offering workshop and training activities in order to reduce any professional discomfort. However, despite these advantages, there is still some resistance to adopt new models and role in palliative care. This way, highlighting a strong need for proper training in narrative medicine. Future work will certainly involve prospective studies to validate the utility of the model and consolidate its benefit both for patients and healthcare professionals in my any care context. Thank you, Abu Dhabi. Thank you, Dr. Neil. Oh, sorry for my English.
Very good.
Thank you.
So we'll do Avtar's chat and then we'll probably take questions.
Okay.
Excellent stuff. What we'll do is we'll crack on with the second presentation. We have around 700 odd, just over 700 attendees online. And I made an oversight yesterday. We didn't ask the almost 1,000 attendees online if they had any questions. So we will correct that error today. So hopefully for the online attendees, if there are questions at the end of this second talk, we will do our best to answer as many as we can. It is my very great pleasure to present the second speaker this morning, Mr. Avtar Singh Cheema. Avtar is a medical social worker and palliative care counselor based in Chandigarh in India. He has a BSW and MSW, these are bachelor's and master's in social work, and currently pursuing his PhD. Avtar founded Palliative Peace, which is an NGO dedicated to providing compassionate care to the destitute in rural Punjab since 2022. And he mentors the International Palliative Care Fellowship and founded the International Death Dweller Foundation to advocate for the role of death dwellers in palliative care, ensuring smooth end-of-life transitions, and offering bereavement support to families. And again, if you're not on LinkedIn and not connected with Avtar, strongly encourage that you do so you can see firsthand the work they do in Punjab. All yours, boss.
ਵਾਹਿਗੁਰੂ ਜੀ ਕਾ ਖਾਲਸਾ ਵਾਹਿਗੁਰੂ ਜੀ ਕੀ ਫਤਿਹ ਸੇਵਾ ਕਰਤ ਹੋਏ ਨਹਿ ਕਾਮੀ ਤਿਸ ਕੋ ਹੋਤ ਪ੍ਰਾਪਤ ਸੁਆਮੀ One who performs selfless service without thought of reward shall attain his Lord and his Master. This is a verse from my holy book, Shri Guru Granth Sahib. Good morning, ladies and gentlemen. It is an honor for me to speak at this esteemed conference, that is first Emirates Palliative Care Conference, and I'm grateful for this opportunity. My name is Avtar Singh Cheema. I'm a medical social worker and a palliative care counselor. I'm a founder of a non-profit organization, Palliative Peace, which works for destitute people who are suffering from life-threatening and life-limiting conditions by providing compassionate care with dignity and respect. Today, I had the pleasure to share with you a talk on palliative care at the center of community, a view from rural Punjab. It is an insight into community-centric approach by Palliative Peace. So personally, for me, My journey into palliative world feels like an endless solitary journey, where despite the countless miles I have covered, I still find myself walking alone. I have stepped into the realm of deep pain and suffering, and people I have encountered, those people, they are still linger in my heart. The weight of their stories, their pain, their sorrow, their struggle accompanies me, making each step feel heavy with emotion. We all exist in a world brimming with pain, sorrow, anger, and joy. For some, life unfolds beautifully and smoothly. But for others, it's a relentless struggle, overshadowed by constant fear of abrupt, untimely end, like a sword hanging by a thread. When Belfair Mount, a visionary Canadian physician, coined the term palliative care in 1970s, he dreamed of a world where patients with chronic, life-threatening conditions would be free from suffering. But little did he know that suffering is not one size fits all. It is deeply stratified by societal layers. Those in high-class societies face the torment of being tethered to their ICU beds, with tubes invading every orifice, a haunting specter of sterile clinical end. In contrast, people in low and middle-class societies endure a different agony. The relentless dread of mounting medical expenses, the overwhelming challenge of completing treatment, all while incurring overwhelming debt, selling their homes, sacrificing their children's futures and their own dreams. Then there are those living in the deepest crevices of society, whose daily suffering goes unnoticed and unacknowledged. These individuals barely survive. Their pain is unseen and unrecognized, living lives of quiet, desperate endurance. After losing my loved one to cancer, I embarked on this journey driven by pain and helplessness that I witnessed. When she was diagnosed with cancer, we only had 4 months to care for her. Unfortunately, due to lack of awareness, I was not aware that the hospital she was taking treatment at had a palliative care department. It was lack of advocacy, and I would have taken some another route to help her. She died in very painful death. Every time I visited a hospital, I saw people lying on the floors, in the grounds, in the parks, around those towering institutions, all forgotten souls, denied even the basic dignity of care. They are left to crawl in pain and their suffering echoing in every corner. I knew then easing this burden would be heartbreaking and arduous path, but it was the one that I had to take. We all know that palliative care is a specialized medical care given to patients living with serious illness. This type of care is focused on providing relief of symptoms and stress of illness. The goal is to improve quality of life for both patients and their family. Palliative care is based on the needs of the patient and not on the prognosis. It is appropriate at any stage and at any age in a serious illness, and it can be provided with curative treatment. Palliative care is known for addressing 4 fundamental aspects of a patient's life: physical, social, psychological, and spiritual. Yet in reality, covering these domains can be an immense challenge. Those enduring physical pain often find themselves without resources necessary to ease their suffering. Social pain becomes more profound struggle as patient wrestles with the memories of lives once lived, now overshadowed by absence of loved ones, fractured relationships, and the deep wounds of isolation and loneliness. The psychological pain born from the emotional and mental torment inflicted by their illness is equally daunting. Patients abandoned by those they once held dear are left with little hope of regaining their independence, restoring their identity, or reclaiming a future that now feels lost. The existential anguish that consumes them as they grapple with overwhelming questions of meaning, fate, and often spirals into a deep depression, leaving them adrift in a sea of despair. We all know that only 2% of patients suffering from terminal diseases receive palliative care when approaching end of life. We created Palliative Peace with a mission to serve unfortunate ones and we give them care with dignity. Palliative Peace was founded in 2022 as a trust that would outline and redefine the palliative care in the rural Punjab. We studied from the pioneers in the palliative world, and Pallium India was one such organization, and Dr. Raj Gopal being the first mentor to guide us right from the beginning. Palliative Peace is a beacon of hope for those who are suffering not only from pain, but also are in social distress. The need of palliative care in Punjab is hurdled by significant challenges in rural healthcare. There are limited healthcare structure, infrastructure, and resources. There is a high prevalence of chronic and terminal diseases, and there is a lack of awareness and access to the palliative care services. Government is already working on many aspects of healthcare, but overpopulation in our country is an overwhelming burden. Punjab has a total number of approximately 1,300 villages, and 58% of its total population lives in rural areas. Mostly all the primary healthcare centers, against the required, the state has a significant shortfall of the required numbers, and the same goes for the community healthcare centers, where shortage is even more pronounced with required to serve the rural population. Palliative Peace is dedicatedly serving the infamous cancer belt of Punjab, the Malwa region, where our patients range from geriatrics to pediatrics. Through my international fellowship in palliative care, jointly conducted by Institute of Palliative Medicine, Kerala, and St. Christopher Hospice, London, I gained invaluable insights into embracing a community-centric approach to care. I was fortunate enough to have Dr. Suresh from Institute of Palliative Medicine as my mentor, who paved my way into the embracing community-centric care, and that I learned from his fellowship. So what is a community-centric model? The community-centric model focuses on providing healthcare services by actively involving and integrating the community in the care process. This model emphasizes local engagement, education, and empowerment to ensure that care is holistic, accessible, and culturally relevant. There are multiple ways to engage in local communities, such as through regular health camps. Palliative Peace utilizes local resources like various NGOs, WhatsApp groups, trusts, etc. We have developed a support network for such as by appointing patient navigators upon referrals to the tertiary centers by our team. We engage the community in the care process. We provide home-based palliative care services, and we train local volunteers and the caregivers. Palliative Peace has trained 3 batches of students doing masters and bachelors of social work. They were given certificates on introduction of palliative care. The reason for starting this program was to spread awareness on palliative care, as many students are from different parts of India. We had hoped that these students will spread the awareness in their own regions after completing their studies. So this is a Palliative Peace model which we have created. It's a community-centric approach model. So Palliative Peace model is a community-centric model designed to help both beneficiary and the benefactor. Model is designed in such a way that it employs community resources along with community involvement. The model has some vague features of community organization, community development from a social work point of view. The patient who is in need of help contacts local NGO or a trust or any WhatsApp group who are working in his or her community. It can be any group working on any social cause. There are a number of groups working that operate in Punjab. These groups have several volunteers who help needy people. When the patient has approached the local NGO starts to seek help for the needy patient from within the community itself. This help can be in the form of financial, social support, spiritual support, or psychological support. Now, when the word of a needy patient get echoes in the community, the people in the community starts to collect resources mainly covering the financial aspects of the patient. Numerous groups in the community work to collect funds for the patient with the assistance of local NGO. Having adequate resources, the patient is now ready to be moved to the next level for medical expertise, guidance, and the role of palliative peace comes into play here. After being approached by the local NGO, palliative peace details out everything that patient needs or might need in the future. We guide local NGO on patient condition as well as guide the patient's family. We give medical expertise through our volunteering services, volunteer physicians, nursing staff, and veterans in the medical field. We give treatment options and interpretation of medical reports by awarding medical jargons to the family and the local NGO regarding the future plan of action, and a prompt referral is placed into either tertiary center, local government hospital, or a private hospital, depending upon the medical patient's condition and the financial support given by the local NGO. Thus, the patient is enrolled as a palliative peace patient and referred to the hospital. We also provide patient navigators for the hospitals to the patient and for the family for smooth and hassle-free initiation of treatment. It is important to note that most of our patients are from rural areas, and the referring NGOs are also from the same region. Thus, they have very less maneuverability to access the medical care due to high literacy rate, lack of knowledge, and lack of communication skills. So the palliative peace thus becomes an conduit between the patients, medical professionals, and the families. With the above approach, a patient who was first reluctant to come to the urban city to get medical treatment from the remote regions of Punjab starts receiving treatment. A mutual agreement is signed between local NGO and a palliative peace to mutually benefit each other. If the patient is deemed a palliative care patient from the diagnosis and referred to for long-term care, palliative peace handles the patient care from that point onward. In turn, local NGO who has collected funds on behalf of the patient disperses some funds to the palliative peace to run our destitute center, and we provide medications to the enrolled patients in palliative peace who are not able to afford expense of the treatment, provide ration support to the underprivileged and under the palliative peace, and we fund home visits and private consultations from medical experts for palliative peace patients. In the ongoing mutual agreement, palliative peace provides free admissions and long-term care to the patients of local NGO, gives appropriate follow-ups, help again by providing patient navigator, medical advice, etc., and thus giving a good reputation of local NGO in their own locality. So I have some few cases which I wanted to share with you all, because each case has taught us very valuable lessons and helped us get more refined and acknowledge the real meaning of being a human being. This was Simran. She was a 7-year-old girl child suffering from terminal right orbit malignant rhabdomyosarcoma. She was under our care for 1.5 years. At first, family was very reluctant to pursue medical treatment due to their financial condition and distance of travel. They were, however, convinced by us that all medical treatment, expense of stay, and everything that family will need will be borne by the palliative peace and the referring NGO in her own community. So unfortunately, due to her advanced stage, she was referred to us for end-of-life care, and we took care of the child until she passed away. This was our last goodbye to her, and we have many memories attached to Simran, and we pray that she be blessed for eternity in heavens. Shyam was a 13-year-old child with subacute sclerosing panencephalitis who came from Uttarakashi. It's a very far away city from where we live. It's in a different state of Uttarakhand. He was referred to us to coordinate his care and sought a second opinion as the child was already on end-of-life care. The referring NGO and us mutually agreed to bear expenses of treatment, travel, diagnostic tests, and stay at the palliative peace center. The child was mute and had hyperflexed extremities. After unfruitful second opinion, child returned back to his home after 2 months stay with us and soon passed away in the comfort of his home. We educated the parents on how to care for Shyam, how to maintain hygiene, what diet should be given, and how to do skin care. According to his parents, Shyam had a very peaceful end. Noor was a very special child. And this child I cannot forget in my dreams also. Noor was a 3-year-old girl child. She was diagnosed with terminal retinoblastoma. She was referred by a local NGO. We took Noor to a palliative care department when her active treatment was exhausted. We went to her native village, planned symptom control with local RMP, created a social network support, engaged a local spiritual leader for the family, provided financial help to the family, and coordinated with the local NGO. We used to visit Noor twice a week to check on her well-being. Unfortunately, Noor passed away, and I was present when this happened, as I recited religious prayers on her bedside at that time, and she went into the light soon after I finished reciting those. Her death was not painful, as we had placed her in comfort of her own home, and she died very peacefully. Vikas was another sweet child. Vikas was a 12-year-old boy who was suffering from terminal ALL. His days were numbered when he came to us. He was referred through a local NGO working in his area. Vikas always wanted to go to a shopping mall, but his father couldn't afford because they were laborers and doing menial jobs. Considering his last desires, we created a memory for him by taking him to a mall in his hometown, had him play games, and we had a lunch at a very good restaurant in his hometown. We did this to make sure that when he'll be drifting in pain and agony at the last moments of his life, he must have something good to remember at that moment. So Vikas died last year, and his death was very, very painful due to severe pain. We tried to knock every door for this child to get morphine, but we were not able to get it due to lack of awareness and myths related to morphine use. Ahmed was a destitute who had suffered critical head injury and was in a coma. He had no one to care for him. Villagers in Ahmed's area approached us to take him from there so that his wounds could get treatment, as he had very foul smell in a shed where he used to live, and it was winter time. We went to his village, took him under our wings, and he passed away after 2 months, and we performed his last rites according to his faith. From a very small 2 rooms at a local Sikh temple, our services got noticed by philanthropists in our community who kindly donated her ancestral property in the remote area of Punjab, and we created Captain TPS Gill Memorial Care and Sport Home. We expanded from 12 beds to 12-bedded palliative care center, and we were fortunate enough to have Dr. Abhijit Dham, founder of Koshish, an NGO working in Jharkhand, as our first palliative care physician volunteer. So we need to, in our daily lives, we need to stop and appreciate a little small things. And such was with this patient. It was a day when our end-of-life patient, Bablu, got a small radio. He has been desiring this for so long. Bablu used to sleep on the floors of outpatient department and in the parks of a hospital for 1 year to get treatment, as he was a destitute suffering from buccal mucosa cancer with extensive fistula. He was referred to us by a government hospital for palliative care. When I went to him, he immediately told me that he saw me in his dream, and he knows that he will die peacefully in my arms, as if he has seen the future. He stayed with us for 6 months and died peacefully in our center. His last rites were performed by me according to his wish. This is a Pathi Singh. He was suffering from oral cancer, a 60-year-old, and he was with his family, but family was not able to care for him in their home due to the small space. And he had very foul smell from his wound, and his conditions were worsening day by day. Despite being a non-medico, it was the day I had to clean his mouth and remove the debris to maintain oral hygiene. Pathi Singh passed away in our center after 2 months of palliative care. His last moments were witnessed by the family who were satisfied that he died a very dignified death. So these were the things that being non-medical I have to do, but it was satisfying for me that I had served that person and I'll remember him for a long time. So it's a case of, Inderjeet, it's a case of lack of involvement despite having a palliative care department in your hospital. The reason being, you're not equipped with persons or compassionate individuals to care for a destitute person. So they referred that destitute patient to us. He was a daily wage laborer who was referred to us due to foul smelling, buccal mucosa carcinoma. And again, despite being a non-medical, we took advice from our volunteer physicians on how to eradicate smell and care for him. We used charcoal dressings along with paraffin gauze on him to prevent foul smell. Inderjeet passed away at our center and taught us how to be more compassionate. Should I skip? Okay. We are very focused on providing spiritual support to our patients, as this is the only thing that is under our control, not their pain, not their physical symptoms, and not their distress. It's my daily routine to sit alongside my end-of-life care patients and recite prayers, asking for a very peaceful transition from the Lord. This is a 26-year-old girl whose name is Muskan, with progressive motor neuron disease, who is declining rapidly. She was abandoned by her family as they were not able to care for her. She is right now under our care beside other patients, and Muskan is our end-of-life patient who has no speech, inability to swallow, stand, walk, with pseudobulbar affect. We are right now planning advanced care directives for her because soon she will go in a phase where she will not be able to vocalize her choices regarding the aggressive medical treatment. We are pushing ourselves to reach. Now, the future of palliative care is that we are pushing ourselves to reach all those who are in pain and distress. We want to play our part in society in relieving pain and suffering and help creating a compassionate and empathetic society. We are integrating with other organizations to work and learn from them. We are in the process of advocating palliative care by providing observerships to the students at our center, providing internships to the nursing students, and create palliative care volunteers, and we are channelizing to promote palliative care. We hope to make world the pain and suffering-free world for all. Last but not the least are these people who have been standing with us from shoulder to shoulder. These are the people who have been helping us for a long time, since the inception of Palliative Peace. These are Punjab Aid, Anmol Jivan Society, Seva Insaniyat e Naate, it's a WhatsApp group, and Baba Ratan Dev Society, Social Work for Helpless People, again it's a WhatsApp group, and Social Workers Samana Society. I thank you all for your patience listening. I am hopeful that my talk had shed some light on how we work in resource-poor settings by improvising the ways to help people who are less fortunate and need compassionate and dignity care. I seek help from you all to help us reach people who are living in shadows, in pain and sorrow, and with no hope of rescue. Again, it was not possible to reach you all without the help of Dr. Neil and the organizers of the conference, Burjeel Holdings. I thank you all from my core of my heart to giving us this opportunity to share our work on a global stage. Thank you so much.
Okay, again, lots of tissues being used this morning. Thank you very much, Avtar. Thank you, Danila. Can we have you up on stage? Because I think we do have some questions. So we have a total of just under 900 online attendees. So again, if there are questions, can we get you to use the microphones? If there are no questions, I've got some online questions to start with. Please.
Thank you so much. I'm Faika, new to the UAE palliative care consultant in Dubai. And I've got some reflections, but I also have some questions. So, Dr. Danila, my first question, I suppose, is to you. Do you feel that your model is an advanced level of psychological care? Is that where you see that, where it sits?
She will answer in Italian and I will
Okay.
translate.
Thank you.
No, è un approccio globale che integra diverse dimensioni, diversi aspetti in collaborazione con psicologi, medici, social worker.
No, it's a holistic global approach that integrates inputs from a lot of different social workers, psychologists,
Okay.
clinics.
Okay, thank you. Thank you. And mine is reflections, really. So, Mr. Aftar, I am so humbled by your talk. So, I've worked in the UK for nearly 30 years. I've been here 3 months, and within weeks I was complaining about what I don't have over here. I don't have a hospice, I don't have all the drugs I need, medical insurance causes so many problems. And actually, after listening to both these talks this morning, but yours particularly, I've got 2 reflections. One is the importance of being seen and heard. So, you know, we can't always alleviate suffering, we can't stop people dying, we can't resolve issues for some people, but actually being seen and heard is therapeutic. And the other part really relates also to Dr. Joy's talk from yesterday, which is around we're struggling for finance in the UK. We've had this gold standard model of palliative care, now we're struggling to fund it. And I suppose the other reflection is the importance of charitable and community initiatives, projects. They seem to be the backbone of what we can deliver in palliative care.
Yeah.
You know, healthcare professionals can do so much, but the rest, without your initiatives and other initiatives, I don't think we could deliver what we do. So thank you.
Yeah, thank you so much. Actually, the thing is that when we start thinking of funds, that how to support our programs, means how to support our organization, it is always heartbreaking, because people, they have some people who are wealthy enough, they know that they need to give to the organizations, but they tend to give to those organizations who are already developed, who are already on the cream side, who have so much funds that for us it's just a wastage, and we need funds just for 10 or 20 people, maximum 13 people I had in my hospitals. That's all, because people come and they die, and we need funds just to sustain that 10 people, 8 people. Right now I'm having 6 people in my hospice, and all are on end of life. So we need to realize in our society that this should be, approach should be equal.
Thank you. Nuan.
Seem to be working, but question to Daniel. Lovely. Do you all have follow-up sessions, and the therapeutic intervention that you do, does it have ongoing effects beyond that therapy session itself?
So every time that there is a narration, there is a subsequent follow-up session where there is an analysis of the narration. And then there is the IPOS analysis.
Okay.
Quando iniziamo la presa in carico e poi dopo 7 giorni la seconda somministrazione dell'IPOS.
So there is the first administration of IPOS, and then after 7 days there is a follow-up session to understand how it is going.
Thank you. The next is regarding Chima's talk and a reflection. I am originally from Sri Lanka. We are a multicultural society, and we have lots of tiers in the different religious circles as well. So one of the things that I see is that people love to do charity, but they also want some gift from God, so to say. So you see people donating lots of stuff to temples. Maybe it's, we have like the clothes that the monks are supposed to wear, but there's an inequality. There will be a lot of suffering, and as you said, the ones that are well recognized get more and more funds, whereas there are smaller, charitable organizations which are always struggling for funds. And recently, an initiative I saw was that some of these religious organizations, rather than getting their devotees to bring the 100th piece of cloth to be worn by a monk, they're saying, why don't you just give that charity to somebody who can make more use of it? So hopefully we will have, people thinking in different ways and more people getting, the care and support that they need from organizations like yours. Thank you.
I think the importance of telling stories is very, very clear. Again, like Faika, extremely humbled. And I kind of made the decision a long time ago. We all talk internally as teams, say, God, this is really frustrating, that is frustrating. But generally, we always end those conversations by recognizing that there is always somebody in a much less fortunate position. So yes, everything is relative. But again, I think if we lose the recognition and awareness that there are people who don't have a voice, who nobody advocates for, then that's as bad as doing nothing, which is why it's very important to give you the opportunity to spread the word. If you look at the last, I think, 5 to 10 years, there's been an explosion of medical humanities. This is why there's so many books being published. Every couple of weeks it feels like that there's somebody telling a story, because these stories matter. Stories reach out and touch you in the heart, so it's important. And again, the question is then begged. We are preaching to the choir here, so how do we get these stories out to the people that hold the checkbook? I don't know the answer, but clearly together we will figure it out. So, excellent. We have 2 questions from the guys online. We have just over 800 people online, so 2 fairly simple questions. One to Danila. How many nurses are doing your NAMPAC, narrative medicine program? And to Avtar, what are you going to do next to try and engage with local government in your area to try and get more sustainable funding?
Actually, we are a new organization compared to others. So we can't apply for government grant funds according to our rules. We need at least 3 years of work in the field, then only we'll be able to apply for FCRA. We are having, for local donors and all, we are having ATG and 12A. In that way, they can get rebate from government while filing their income tax. But if we see that we want funds from abroad or associate with foreign organizations and all, it is still hard for us. We have to wait another year, then only we'll be able to do that. But people are helping us out of the way. They are, sometimes they try to give money through other accounts and all, and they put it in their local, to their local relatives and all, and they try to donate us because they recognize our work. That's it.
So currently she goes around and collaborates with the local structures
But from 2025, there will be a specific course that will help to train professionals. So both nurses and doctors and other figures.
Thank you. Any other questions? Anybody else? Comments? Please. The microphone's just there.
My question to Mr. Avtar. Do you have any organizations in the similar way what you are operating in Punjab, in Kerala? Because I am from Kerala, so I think that will be more easier for me to approach.
Yeah, yes, we have. Actually, palliative care was started, the base of palliative care in Punjab was started right when our gurus were there.
Okay.
We call them Pingalwada. Home for
Come again?
Pingalwada, Pingalwara. You can search it. We call them Pingalwada. Those are destitute homes.
Okay.
In there, people come, they get people from the streets and all, and they help them, they give them food and shelter. And it is, for Punjab, it is nearly in every city of Punjab.
But in
Pingalwada
Kerala?
is there. And we have very good organizations like Serve Humanity, Serve God, Manukta Di Seva, and Apna First. These are the societies that work in similar way we work. And they also rescue people. Punjab is a very compassionate people, so this thing straight. So people do work.
Okay.
They work in this way, means compared to other parts, means compassion is more palpable in Punjab. So there are a lot of societies, they work, but again the thing is that they don't get recognized.
Okay. No, not required actually, but in the similar way, in the palliative care, is there anything in Kerala in your knowledge? Because I don't know, I'm not from
In Kerala?
Yeah.
Kerala...
Because you were talking about you went there and you have some doctors from there.
Because I learned everything from Kerala.
Okay.
We all learned everything from Kerala. In India, whoever is doing palliative care, they have learned from Kerala.
Okay.
And he is the person from whom we have learned, Dr. Raj Gopal.
Okay.
I think he's the best person to answer your question about that.
Please.
Before I talk of Kerala, what I believe is that there cannot be any community anywhere in the world where there are no people with compassion. They are there. How can it be that a community does not have compassionate people? I believe the problem is we do not let them into the healthcare scene. We have security guards keeping people out. We have systems in place and processes in place and KRAs, key result areas.
True.
No sense going and talking about KRAs to the community. The people need an opportunity. And whether it's Punjab or here, or I heard about compassionate communities in Canada, Australia, 30 counties outside of London in the UK, they are evolving. We need to give them an opportunity and make the work visible, which is what Dr. Avatar is doing. And there are more than 350 small community-based organizations. The important thing is, they should not be branches of my organization or another big organization. They should have ownership on what they do. They should be able to take pride in what they do. If we try to own them, they will break free. One other point arising from what Avtar said and what you brought up, Neil, I would welcome funds from the government, but always there is a problem. Our governments in low and middle income countries do not usually operate the same way as the global north does. Just 2 sentences more, sorry. The HIV treatment facilities in India was an example. It was funded by the government. there were numerous care centers in various parts of the country for about 17 years. Then all of a sudden, a big lord came in charge of the whole thing. That person announced, now that antiretroviral treatment is available, care centers are not needed. And within 1 month, except 1 or 2, all of them shut down, with the people out on the streets. So government grants are great. If the government comes and offers me $1 million or even more, I would certainly welcome it. But I believe that it is most important to have roots in the community. And when they are there, even if I have to scale down the operations, then I wouldn't have to shut down. Thank you.
And I think this is the whole purpose, the ethos of compassionate community. Care is not the sole domain of the healthcare provider. You know, we are all parts of the community. We are responsible for those of us in our community who become unwell. It is not always easy to set up a compassionate community, but I will say, I always try to take something away from a conference, and I've been a palliative care doctor for a few years now, and every time I go to a conference, I often come away thinking nothing that I have learned or encountered is going to change my practice. So from this meeting, I think we will push harder to try and make our compassionate community here in the UAE more meaningful. And secondly, this has been raised quite a few times, this need to do something different for the global south countries. The fact that we hear the suffering, we see the inequity, the lack of access, and then we go home, resume our normal lives, and kind of forget about it. So I will use whatever influence we have with our local WHO EMRO group and try to do something to sort of push and use the UAE's voice to try and do something for our colleagues and patients in Global South.
One more question, please. One more question. Like,
Okay.
as in continuation with Dr. Rajgopal said, we know, like he said, there are 350, and we are all living in here in UAE. In my knowledge, I think only Burjil Hospital is doing the palliative care, especially because I'm a common man, I don't know anything about all this. So there should be someone to let this common people like us to know there is a need. There are so many, even when I talk to my friends, many people want to do, but they're all afraid, especially this country, norms and all. So we need help from your part to come to know there is a need, and so that people can engage in, like common people can engage.
No, there is, and we need to find a way to, as Dr. Raj was saying, bring people back into healthcare. We do have a specific challenge in the UAE in that there is so much regulation.
Yes.
It doesn't come from a place of malice or being just difficult. It is because they're trying to keep things orderly. But I think there's been a little too much regulation in that regard. So again, we have to advocate, we have to have many, many people aligned and saying the same things, and it will happen, but you have to keep knocking on the gate. You have to.
Thank you.
Okay, thank you guys. Excellent session this morning. In order to try and make up some time, are we allowed a coffee break? So you're allowed a coffee break, sort of 5-10 minutes maximum, and then we will launch straight into our workshops. So just a few presentations.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn.
Oh my goodness.
We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
Can you see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
The spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision on the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. So Mary once jokingly said to me, Doctor, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me, shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burgil Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burgil Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burgil Medical City, getting you ready for life.
At Burgil Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rates stand shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalized care, we've made substantial strides in enhancing patient outcomes and quality of life. Burgil Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimeter precision. We also offer pediatric radiation therapy and meticulous bone marrow transplant planning. with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we lead the way in paediatric orthopedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopedic care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology to handle over 80% of surgical procedures with unparalleled precision. Our specialists use the state-of-the-art Da Vinci Xi surgical system, enabling complex operations with exceptional accuracy. This advanced technology provides 3D comprehensive vision and highly dexterous robotic arms, ensuring surgeries are performed with supreme precision, care, and efficiency. Patients benefit from minimized surgical intervention, leading to quicker recoveries and shorter hospital stays. Plus, Burjil Medical City offers extensive rehabilitation and physiotherapy services to support every step of your recovery journey, because every surgical journey towards a better life deserves the pinnacle of precision and care. BMC, Burjil Medical City, getting you ready for life.
Mariam worked hard to establish her company, and the idea of giving up never crossed her mind. Every moment was crucial in bringing Mariam back to her life and her work. Our medical team at Burjil Medical City knew that Mariam's case was sensitive, especially since the type of cancer she had was rare and needed to be addressed as quickly as possible. For this, our specialists in gynecologic oncology relied on minimally invasive robotic surgery to remove the cancerous tumor, ensuring high precision, reduced pain, and rapid recovery. After comprehensive analyses and examinations, we scheduled Mariam for advanced radiation therapy sessions to eliminate any remaining cancer cells. The moment Mariam re-entered the company premises is one that no one will ever forget. BMC, Burjil Medical City, getting you ready for life.
The wedding of Saeed's first granddaughter was approaching, but severe gastric volvulus had overshadowed his joy. We were racing against time to bring him back to his life and home. The medical team at Burjil Medical City was prepared for Saeed's complex case. To address it, we performed a precise and minimally invasive robotic surgery for subtotal gastrectomy, removal of the surrounding lymph nodes, and accurate reconnection of the digestive system. This approach accelerated the healing process and allowed Saeed to regain all normal digestive functions. Thanks to our deep expertise and advanced surgical techniques, we were able to restore Saeed's happiness. Everyone turned to look at Saeed with joy, surprise, and amazement as they saw him standing. In that moment, their happiness was complete. BMC, Burjil Medical City, getting you ready for life.
Hamdan's dream of winning again seemed unimaginable. Every second mattered in returning Hamdan to his life and passion. The medical team at Burjil Medical City was aware that the fracture near Hamdan's knee had affected his growth, causing his leg to become shorter and more curved over time. To address this, our paediatric orthopedic surgeons inserted a precise intermedullary nail into the bone to straighten and gradually lengthen the leg until it matched the other leg within just a few weeks. Followed by a customized rehabilitation program, Hamdan was able to resume most of his activities within 3 months. The moment Hamdan stepped back on the pitch, it was a victory before the victory. And now, everyone knew who the school's new top scorer would be. BMC, Burjil Medical City, getting you ready for life.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn.
Oh my goodness.
We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
Can you see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
The spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision on the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. So Mary once jokingly said to me, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me. Shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burjil Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burjil Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rates stand shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalised care, we've made substantial strides in enhancing patient outcomes and quality of life. Burjil Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimeter precision. We also offer pediatric radiation therapy and meticulous bone marrow transplant planning with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we lead the way in paediatric orthopedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopedic care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology.
Okay, is it morning? It's still morning. Guys, just for the workshops, as this is a much smaller select group of people, can we get you to move forward just so it makes the workshops a bit more interactive? We won't pick on anybody, but if you sit all the way at the back, then we'll direct all the questions towards you. So please come forward. It's a huge room. We probably can fit everybody on the first 2 rows of tables. Thank you.
Hi, good morning, everyone. So, shall we? Okay. So I'm really excited to be with you today, and I'm again honored to participate to this wonderful event. Thank you, Neil, for organizing this wonderful conference. So today we are going to do a quick workshop about pain. Before starting, just to know better our audience, among us, who is not specialized in palliative care? Just can you raise your hands? Who are not palliative care specialists, nurses or physicians who is not specialized in palliative care. Excellent. So move here. Please, there are many places like this. It won't be a lecture like this. We can talk together directly. Please come on the front. There are many chairs and come. No? Bye. So I will, we have been introduced yesterday already. I'm Dr. Hamadi. I'm a consultant in palliative care. I currently work in Saudi Arabia and at King Faisal Specialist Hospital. And beside my clinical activities, I also supervise palliative care fellowship training program. And Dr. Sana was one of our fellows, and she graduated now. She's a consultant, our colleague. And she finished her fellowship with great performances. So I'm happy to be with her today to do this workshop together. So let's start.
I just want to ask who's gonna...
We need the...
So good morning, everyone. As Dr. Hamadi introduced us, my name is Sana Sulaiman Al-Zairi, and I'm from Princess Noor Oncology Center in Western Region, Saudi Arabia. It's a very pleasure and honor. Dr. Neil, thank you for inviting me to talk in the first Palliative Emirates Conference. We'll be together for approximately the next 60 minutes, so hope everyone can enjoy the ride. So the assignment have been given for us was talking about pain and opioids. Let me go through the goals in briefly way. First, we'll provide comprehensive knowledge on pain management and palliative care. Then we'll address the use of opioids, safe prescribing, and go through the guidelines with the non-opioid alternatives. Then we'll have an engagement of participants in case of based learning, practical applicants. Then finally, we will close with identification of terms to opioid misuse and opioid prescribing challenges. So this is our timeline. We'll have a breather, like
move forward.
yeah, we'll have a breather 10 break minutes between the 2 sessions. So okay. First case, can you, Dr. Hamadi, illustrate?
Yes. So let's start with this first case scenario. So Mr. D is a 65 years old gentleman with advanced pancreatic cancer, metastatic to his liver and bones. He was referred to the palliative care team after his oncologist determined that curative treatment is no longer an option. Mr. D's main concern is pain, which he described as unbearable and constant, especially in his lower back and abdomen. He also experienced intermittent sharp pain in his lower limbs. So our first question, how will you assess his pain? I will ask this question to our participants who are in the back, ladies. So, can we start with your table?
Well, my name is Cindy and I'm a nurse. So usually in our practice, we usually assess the pain of our patient by asking them, how was it, how's the intensity, how long that is last, and then what they do to relieve the pain, or if there's anything that we could help. Or when we give the medication, we will ask how long it's to take effect, and then we'll just observe the patient with the verbal cues if ever the patient is not able to speak.
Excellent. So effectively, there are basic elements to assess a pain, including the site of pain, the type of pain, and the intensity. Is there any factors that increases the pain? And for this, we can also use pain scores or pain assessment tools. This is what we're going to explore now. So let's continue our case scenario. Mr. D is a known case of type 2 diabetes. He has hypertension and chronic kidney disease, which complicates the management of his pain. He rates his pain as moderate to severe. His current regimen is morphine subcut 10 milligrams every 4 hours. In addition, he has PRN doses of 5 milligrams subcut every 1 hour. He received in the past 24 hours 7 breakthrough doses. Also, he is using gabapentin 800 milligram TID. Just want to add that his kidney function has declined lately. His liver functions are still within acceptable rates. So, Dr. Majd, what pain management regimen will you start for this patient? Let's illustrate the situation.
Okay, thank you, Doctor. This patient actually now he's in multiple regimen of pain medication, which is morphine as 10 milligram Q4 hourly, and subcut as BRN. Medication is also using element for neuropathic pain, gabapentin. He has decline in kidney function, so he needs to be full assist for any side effect and of opioid and for toxicity. But otherwise, unless on this regimen, he still has severe to moderate to severe pain. So he needs to be looking for maybe upgrade for his medication or alternating medication.
Excellent. Indeed, this patient is having acute pain. He's still having pain, although his pain regimen, but there are red flags regarding his kidney function. So the pain management, which take into consideration these two elements. He is in pain, but he has a kidney impairment. So, have only the same scenario.
Yeah, then he reported that he's experiencing some side effects, such as constipation and nausea for 5 days. How will you proceed? The patient was on big guns of pain medications. Then after 5 days, he explained that he has constipation. What was missing in the management?
What do you think Dr. Ahmed was missing? He had strong pain medication, including morphine, gabapentin at high doses. Did we miss something?
First, I will have to look if there are medications for the side effects he's experiencing, the constipation, if he's on laxative, on antiemetics. Second, I will look for another elements, for example, social, spiritual aspects of the patient. If he's suffering, the pain will not improve. Third, I will look for an opinion from one of our colleagues in pain management, for if the patient is fit, for example, nerve block or other intervention. And I will decrease the dose as he's having side effects, and I will alternate the opioid.
Okay. So indeed, one of the main side effects of morphine is constipation. Although morphine can have serious adverse reactions or more important risks, but they are not very frequent, and constipation is the most frequent side effects of using morphine. So let's explore together first the goals of pain management and the assessment of pain. Please, why?
So please allow me to dig deeper in the pain management goals and process. Before managing a patient, it's simple goals, 5 A's. You should just manage the analgesia, optimize them, activates and optimize the activities, look for the adverse effect, minimize them, look for any aberrant drug taking and try to avoid them, and don't forget to mention the effect. So, according to the European Pain Federation and International Association of Study of Pain, they define that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is also always a personal experience, so you have to pay attention for that, and it's influenced by a variety of degree of biological and psychosocial factors. The WHO stated that the prevalence of palliative patients in need is 56.8 million, and worldwide only 14% have access to palliative care. Pain is the common and devastating complication of those progressive diseases such as cancer and AIDS. Unfortunately, up to 85% of patients with advanced cancer will experience those pain, and 2/3 of them will explain that it's moderate to severe. So, regarding Mr. D's case, how you will explore the pain and how will you categorize it? You can categorize it easily as mild, moderate to severe by numerical tools. If it's mild, it will be from 1 to 3 up to 10. If it's moderate, it will be from 4 to 6 over 10. And if it's severe, it will be 7 to 10 over 10. If that was not feasible with you, you can categorize it by the mechanism of action. It can be nociceptive or neuropathic. If it's nociceptive, it can fall through the category of somatic and visceral. If it's visceral, it can be due to capsular enhancement, bowel obstruction, or cardiac. If it's somatic, it can be soft tissue or bone. The neuropathic classification falls under the nerve compression or nerve injury, which can be peripheral, central, or sympathetic. Another classification of pain, which is important just to know what kind of medication you will start the patient on, is due to the disease itself, if the patient have any invasion of traction of cancer, or due to the treatment itself, if the patient is having any like neuropathic induced chemotherapy. We find a lot of patients from oncology in the clinic with this issue, or maybe the patient has a pre-existing disease that causes the pain, such as fibromyalgia. So it is crucial and important to guide your pain and assess it, because it's failure to, if you failed that, you will not have a good plan of management. Don't forget that the patient himself is the gold standard for a pain report. Most of the patients in palliative care, they have more than one type of pain. So each pain should be assessed separately with separate kind of class of medication. As palliative physician, we always put in our heads the psychosocial, spiritual, shared care planning, advanced care planning, and ethical consideration. And don't forget to have regular interval of reassessment.
So just one remark. Imagine, Dr. Sana, the nurse is coming to see you. Mr. D is asking for the PRN or breakthrough doses, and he says he's in pain, but when we look at him, he doesn't look really in severe pain. Or what would you answer her?
Because, as we mentioned, that pain is a self-reporting. If the patient is reporting that he has pain, you should explore it, whether it's physical or social or spiritual, or he is having total pain. So it's gold standard to believe the patient, especially if he's arousal, he's calm, he's not confused. Then approach that pain in different way that we learned, or we will learn. Okay. So for a physician or a nurse, if the pain was presenting, you quantify and intensify the pain character and quality. You have to have a comprehensive overview, pain experience, etiology, pathophysiology, see if there is any drug aberrant or any diversion. If the pain was not related to any oncological emergency, you treat the patient accordingly, if he's opioid naive or if he's tolerant, which will be expanded in the next slides. If it was related to any emergency, check the patient in the ED room, treat the patient according to that emergency, such as spinal cord compression, malignant bowel obstruction, because it's going to be another pathway, a different pathway. So simple as it, the key element, ask about the onset of the pain, when did it start, how did it start, what is your elevating factor, what is your provoking factors, does it radiate, does it reverse anywhere, the severity, as we mentioned there in the classification. You have to explore the treatment. You have a patient with a malignant disease, maybe he went to another hospital, to different clinics, what kind of medication he's on, is he on any herbal remedies, if he's using any other medication that you don't know about, any side effect has been developed, what is his value, what is his understanding. This is very important key element to explore the pain and have a satisfactory management plan. So simple as we will break it down to simple tools that we use in daily basis. We have the verbal pain intensity scale from moderate to severe. We have the numerical, which is 0, no pain, and 10 is the worst possible pain ever. We have the visual that we can use it for adults and for pediatric patients.
What if the patient is elderly, he has cognitive impairment and or dementia, and he's unable to give a description of his pain or describe his pain?
Nevertheless, we have a lot of pain tools that is published. You can find it, and it's accurate. Anyone can reach for it in the guidelines, but I chose the Algo Plus. It's the easiest. It's only 5 domains. It's for the patient that having acute pain, but it's not communicating. The 5 domains have yes and no questions with 1 point score for every yes. So if you calculated 2 or more scores, that means that you don't have a satisfactory pain management. If it was less, then you're in a good way, good path, just continue and recurrent evaluate. This method has over than 87% sensitivity and 80% specificity, and it's simple, so I advise to use it in our care. So moving forward, we will dig deep in the opioid overview. We will talk about some medication that we use in our daily basis in some details. So let's talk first in brief manners about the mechanism of action of opioid. It is simple that opioid has 3 receptors, the mu, kappa, and delta. They mainly act on the mu receptors that's found in many areas like the brain, the spinal cord, and other tissues. And stimulation of these receptors can occur not only pain management and analgesia, it can reduce gastrointestinal motility. That's why the patient, when started on opioid, can have chronic constipation. So that's why Dr. Ahmed mentioned that we have to have laxatives along with the opioid prescription. It can happen also as meiosis and euphoria, and this is rare, but it's common. You have to keep it in mind. So, for all physicians and nurses around, what is the most medication that you used in your service for palliative, the opioid medications? Just kida in general. Morphine? Yes, morphine is the star. What else? Do you use methadone? Are you afraid of starting methadone? Good, you are. It's common, but we can overcome that fear. What else? Do you use hydromorph, fentanyl? Yes, but always the morphine is the star, okay? So, weak opioid, we always use 2 common opioids, tramadol and codeine. I'll go briefly. Tramadol, just you have to be cautious with patients with increased intracranial hypertension or hypertensive patients or elderly patient or any patient who has history of epilepsy, because it decreases the threshold of seizures. It comes in long-acting and short-acting manners. Maximum daily requirement is 400 milligram, and you can start by 50 to 100 milligram Q6 hours.
In addition, for the tramadol, one of the side effects, especially in the elderly, is the dizziness. This is why we don't prefer to start tramadol in the elderly when they have severe pain. Please, Dr. Abdullah.
Also, we have Also, we have the combination of tramadol and paracetamol with the lower dose.
Zeldiar,
Yes.
right? Yeah, we have it, we use it.
After
Always
a week, opioids?
the combined medication with paracetamol, it's good for the bony pain, and patient is relieved on it, and it's simple and we're not afraid of it. So Zeldiar, yes, it's a good choice. So the other weak opioid that we use is codeine. Codeine also comes in oral manners. The maximum dose is 360 per 24 hours, and it's combined with paracetamol as Tylenol number 1, number 2, number 3. So now weak opioids is not suitable, it's not working, you're jumping to the strong opioid. The golden star is morphine, but you have to keep in mind to start an appropriate dose, titrate, observe, frequent follow-up, pay attention to the relative side effects, to the rare side effects, be aware of that patient that he has some types of pain that needs different types of medications. So morphine sulfate has no clinically ceiling dose because it's a strong opioid. It is an mu receptor agonist and weak kappa. Morphine is the standard starting drug of choice for a patient who has never been exposed to opioid. It's eliminated by kidney, so that's why you have to be careful with patients with renal impairment. It has variety of administration. It can be oral, it can be IV, topical, epidural, rectal, subcut. So
now just we are making an overview about the opioids, and then we'll talk about the opioid management. And so if you have questions, it's coming.
Okay. The other strong medication that we often use is hydromorph, and as we mentioned before, it's a primary mu opioid receptor agonist. Its properties is similar to the morphine, but it's 5 times to 7 times potent than morphine, so the dose will be less. Starting dose will be like 1 milligram. So, but there is some suggestion that it can provoke the myoclonus and hyperalgesia and seizures. Because of the neurotoxicity effect. Then we will have the oxycodone. It's like 1.5 potent than morphine. It's similar to morphine. It also have adverse effect on the kidneys. It's available and it can be orally as 5 milligram starting dose.
And oxycodone is also available in association with paracetamol.
Yes, as Percocet. We call it Percocet.
The commercial name. So let's explore the fentanyl.
For the fentanyl is a semi-synthetic medication. It's a very good medication with patient with renal impairment. It is almost 100 times potent than morphine. It can be IV, it can be as a transdermal patch. The patch is a very good choice for the chronic controlled medications. And it has a high degree of lipid solubility. Excuse me?
As well, there are forms of fentanyl transmucosal, like nasal or
intranasal. In Canada, they used to have the lollipop for the incident pain. So it has a lot of route of administration.
A few words about the methadone.
Yeah, if anyone worries about the methadone, I can understand because it have a long-acting duration. It could be up to 120%. So it's accumulate, then you will start to find the effect of methadone. Although it is a very good medication with high bioavailability, it's cost-effective. It's good to be used for patients with substance use disorder, and it's good for the neuropathic pain management. Also, it binds to different receptors such as the serotonin and MDA, so that's why you will have less side effects of opioid and more affecting plan. Methadone also is available in tablets, can be started by 5 milligram to 10 milligram. It has a lot of ways to start. It can be over a night or it can be continuous over 3 to 7 days. Just before starting methadone, don't forget to order the patient for ECG for the QT interval because it have some cardiotoxicity effect.
Of course, methadone is a complex medication and it needs a workshop by itself, but just an overview.
As I mentioned before, you can start it as stop on go. Just stop the
morphine and
yeah,
then you can
and start it again.
Convert
or
and
it
go.
can be through 3 days. Every day you take off 30% of the previous medication and put new 30% of methadone. Until the 3rd day, it will be continuous methadone. And don't forget to put another kind of PRN medication.
So I will move on regarding methadone because it's very specific and it needs a specific workshop. So when to consider opioid rotation?
As we mentioned, like in that patient, he has morphine, he has gabapentin, he was not released. So this is
typical scenario.
Yeah, a scenario that you have to rotate or change the medication. When you will start to rotate, if the patient has difficulty in tolerating this medication, if he has side effect, if he has poor pain control, or if his renal and hepatic function has worsened.
Like in this case that we explored, patient was on high dose of morphine, pain was still present, and he was having a renal impairment. So this was ideal or the recommended situation to switch to another opioid.
Yeah. So how do you rotate? Simple. See the patient, see his medication, comprehensive pain assessment, calculate the whole dose. If the patient is not on morphine, go to the published ecoanalgesic tables, rotate all the medication to oral morphine, then choose the new medication. So after that, you individualize your plan. If the patient has good control, you can go with the reduction of 25%. If the patient has no control, go with the same dose, and even you can increase it by 25 up to 50%. Nothing is wrong in that. Or you can consider just keeping the same dose and just evaluate after 48 hours and ask the patient to ask for the PRN medication. And don't forget to monitor every 40 hours, change the plan if needed.
Let's have a look about the opioid conversion equianalgesic table. So I think, do you have any questions about the morphine equivalence, or how do we convert from morphine to another opioids? The geriatrician, any questions so far?
So we're gonna wrap this part. I know it's very condensed and dense part, but we have to mention it, so because it's a pain management and opioid workshop. What are the side effects that we are anticipating for any opioid prescription? As we learned in our fellowship program, you prescribe opioid with your hand. In the same hand, you prescribe any laxatives. Constipation will never be tolerated. The patient will complain about constipation as long as he's on opioid. Please choose the osmotic laxatives or the and just be away from the bulk forming and the softener. Nausea and vomiting can be only for the first 7 days if the patient is naive. Sedation can happen until maybe 4 to 5 days. Pruritus also can happen. Respiratory rate, we are not afraid of as palliative, but oncologists always relay any respiratory depression on the morphine. It can happen, it's rare, so just pay attention to that. Give the patient good hydration while starting. So, along with the opioid, we always use the non-opioid adjuvant. It's easy and simple. Principle of adjuvant is what? It's like antidepressant, anticonvulsants to help in treatment cancer pain. The response depends on the etiology of the pain. Like if the patient has neuropathic pain, anticonvulsant will help him or antidepressant. You have to select the medication according to the symptom. Gabapentin and pregabalin are widely used in CKD patients, but the publication of the studies are rare because, you know, if there is a safety or efficacy study, they will not take a CKD patient in that study. But you have to go with the adjustment doses regarding the creatinine ratio. Pregabalin can be metabolized and excreted by the gastric tract, so you can use it rather than gabapentin. Other medications such as depressant, you can use the TCAs, SNRIs, venlafaxine, but be careful with the elderly patient because it has a good anticholinergic side effect and it could be cardiotoxic. Acetaminophen is the star. We keep the patient on acetaminophen. It's a good medication. It's always available. Maximum dose is 4 grams per day. It can be IV. Just the hepatotoxicity is the only problem. The NSAIDs also, it's available. We can use the ibuprofen, naproxen, ketorolac, but you have to be paying attention due to the extreme gastrotoxicity, hepatotoxicity, renal toxicity, and cardiotoxicity, especially with the ketorolac.
So what are the principles of prescribing, initiating, and management of the opioids?
So now as we learned about the medication and what kind of medication is working, where is working, and the side effect, now we can know how to initiate it. I will go through the guidelines of the National Comprehensive Cancer Network, along with the WHO ladder. If it's mild, moderate, or severe. Step 1, mild, you can go with the non-opioid and adjuvant. Step 2 is weak opioid. Because it's moderate pain, you can go along also to the non-opioid and adjuvant. Step 3, go ahead with the strong opioids. So the WHO explains that you can start the medication by mouth, by cluck, by ladder, for individual, and don't forget to pay attention for details and other aspects. Simple, patient is opioid naive. You need a strong opioid. What you will do? You'll see the patient, see his renal function, see his vitals. Everything is fine. Starting dose. Morphine is 5 to 10 milligrams IV. You can put it PRN and see how much he consumes, or put it like in scheduled dose. If the patient is frail, if the patient is renal impaired, go with half dose. And don't forget to re-evaluate every day. Don't forget to put 10% of this total dose for PRN rescue doses. If the patient is opioid tolerant, we will mention that we can have increasement of the dose or changing or rotation. So if you need to titrate, you have 3 ways, simple ways. Take the whole dose with the PRN consumption and titrate it with the original dose, and this is your new dose. Or increase only by the PRN doses, or combine 2 of them. So now we finished the dense part of the lecture.
I suggest that we move on.
Yes, we'll have like break. 10 minutes breather, or you want to move on? Okay.
Yes, please, Katie.
Hello, thank you. Just a brief comment about the opioids, or a recommendation for everyone here. It's really worth checking what opioids you've got available in your place of work. For example, we can't get hydromorphone in the UAE currently. So I would recommend, if you start somewhere new or you're looking at using opioids, that you check with your pharmacy what you've got before you confidently prescribe for your patient, only to find that it's not available. So it's just a tip, really, for people.
Effectively, there is multiple choices for strong opioids, so it depends what is available, and sometimes we have something was available is out of stock, so we need to switch to another one. So that's why
even if the patient is having renal impairment and we are stuck with morphine, we can use morphine with caution and multiple follow-up. We can, as palliative physician, we are used to work around our patients, but the opioid should be available, whatever kind.
Thank you. 2 things. One is hydromorphone, I think, is available in Abu Dhabi. We don't have it in Dubai, just to correct you, Dr. Katie.
I'm sorry.
And the other thing is, my understanding was, just to clarify, because you said, IV can be, morphine can be started IV, etc. So the WHO guideline is that the oral route is the preferred route.
Yeah, we will mention this.
Yeah, I'm guessing you were referring to an acute setting or ICU or somewhere, but the oral route is the preferred route as a starting
Yeah,
for
always.
strong opioids.
Once the patient can eat, can talk, can tolerate orally, always the oral route is the preferable route of starting the opioid.
Any questions? Yes.
I just had one question. Unless I've missed it, the slide with the adjuvants didn't mention duloxetine.
Yeah, I mentioned it was in the table.
SSRI, we put it in
Yeah,
SSRI.
and we use it for chemotherapy-induced neuropathic pain. It's good, good medication in that.
And many studies shows its efficacy in fibromyalgia.
Because the schedule had a lot of medication. I don't want to read them all, but it's
okay.
there.
Can I just, I'll do the online question.
Please,
so there is a question. This is from Pranjal. So where is buprenorphine considered here? He didn't see it in the conversion table.
Yeah, it's there, but actually we don't use it. It's not available. I've never seen it. And I had slides on it, but I decided to not talk about something that we're not using it.
Effectively, buprenorphine is one of the strong opioids.
Yeah. And the patch can stay for 7 days. The doses are quite good and available, but I work in the second biggest oncology center in Saudi. It's not there.
Okay.
Dr. Mohammed works in the first biggest. I don't think, do you have it?
No, we don't have it as well. What about UAE?
So we are fortunate here. We have 5 and 10 microgram per hour strengths with the 7-day preparation.
Yeah.
And I will say for the geriatricians will back me up here. Butrans 5, the lowest strength patch, is beautiful in the geriatric population. It's such an excellent drug. All the comments you mentioned apply, but if you're really, really struggling, it's clear clinically from assessment that the patient really has pain, but you're not able to get it out. You think this is likely to be severe pain, and we often have to prescribe empirically and then reassess to say Butrans 5 is a beautiful choice. Safe in renal impairments, well tolerated with even moderate hepatic impairment, but we have it in the UAE.
Excellent. Please.
What are your thoughts about ketamine? I know it's been traditionally used for post-operative pain, but I think in the U.S. it's gained some popularity.
Yes,
as for chronic pain as well.
Indeed, ketamine is a strong opioid, and it's useful for many situations. In our palliative care settings, or when we accompany palliative pain in the palliative care patients or other serious illness, ketamine can be used, in our experience, as an adjuvant to help the pain management alongside with other opioids. But nowadays, there's a trend, especially in the US, to use ketamine for other aspects, such as chronic depression and but yes, it's a useful medication, but we need to be cautious with indication. Yes, Kim?
We have a poster actually for kids. We did a review, me and Dr. Khalid, for ketamine use for chronic pain in pediatric, for malignant, non-malignant condition, and just published. But so far the evidence is not, there's no strong evidence for both either malignant or non-malignant for chronic pain management in children, but it can be used in case of refractory pain and you've tried other things before. There's an option that you can look at for kids.
Hi, sorry, just one question online from Dr. Sajid in Malaysia. Can you please explain a few points comparing methadone and morphine?
Comparing?
Comparing methadone to morphine, just a few points.
Methadone is quite potent than morphine. We use it as oral base. We don't use it as another route. Methadone has a very long bioavailability, like 120 hours. Methadone is used to the substance use disorder. It's cost effective, it's cheaper than the morphine. What else, Dr. Hamadi?
You can use it when we have a resisting pain and it's not responding
it's used
on the opioids.
when you struggle with your pain management. The patient is on high doses of morphine or hydromorph or fentanyl and still resistance. Methadone is always a rescue. But methadone, you cannot use it with compulsive patients because it's long acting. If the patient was compulsive and not accurate, you can go through the toxicity
What is
easily.
complex also with
Yeah.
methadone is its metabolism. It's interfere with a lot of other medications.
It have a lot of drug interactions. And you know, our patients are taking TCAs, SSRIs, benzos, all these medications have interaction with methadone. So that's why for us, we keep it as the last resort because you need continuous follow-up for the patient, not such as the morphine.
So difference, for basic pain management, the preferred first choice is the morphine.
Yeah. Morphine long-acting cannot be also crushed, cannot be diluted. Methadone, if you have to, you can dilute it, you can crush it.
Difference.
Yeah, and the thing about availability, so we get a lot of patients coming back from treatment abroad, Canada, US, and they will often come back on methadone.
Yes.
If for whatever reason the oral route is lost, we only just
have no options.
We only just got the methadone injectable preparation in Abu Dhabi.
Okay.
So it is available, but again, I've not used injectable methadone for 9-10 years. I just haven't used it. So you really have to be aware of what opioid you have in stock when you accept patients.
So you mentioned that methadone can be used someone who has substance abuse. So so if I have patient who's elderly on chronic opioid and get prescribed for no strong indication, a patient develop this dependence for the things. Can I use methadone with, I mean, refer to the pain specialist who can use methadone as a bridge to get rid of the opioids? And after that, I mean, like if we are able to get rid of this opioid, this patient can be also, methadone can be stopped after that. Yeah.
So your question is patient is having a medication abuse with which specific, was opioids or was some? Okay.
Has been like they have weeks of indication for prescribing, and the patient after that is not able to. We are not able to stop the medication. Okay. And one suggestion was with the pain specialist to give the patient methadone as a bridge. Okay, just to help.
So your question whether if methadone can be used as a bridge to stop, for example, someone who is on long-term of fentanyl or opioids, it's not the specific indication for methadone. Methadone is more for resisting pain, challenging pain. But I think the best option for this kind of patient is to have someone from addictology and other solutions. Yes, Dr. Faiko?
So my experience of methadone in drug dependence has been they may be on methadone as maintenance coming off, but I would want that done by a specialist centre. I would not want to be in charge of their addiction. But obviously these patients may well have pain due to other causes, and in the past the methadone then becomes their maintenance in the background, and then you use a second opioid for their pain. But we have always liaised really closely with the addiction centres. It's not something that I would take on.
Yeah, we want to be clear. If we use it this way, it's for the addiction, not the physical dependence or tolerance, because our patient more likely develop physical dependence and tolerance, and it's okay for the cancer patient. It's common and it's expected. For the addiction, which means that the patient is using the medication without any medical reason, with the physiological and physical damage, with the withdrawal symptoms, yes, you can use the methadone. But for our patient, if he's dependent or tolerant, you can go through that with upgrading or changing the medication.
As I said previously, methadone needs to be prescribed by specialists who are very experienced in using the methadone. And methadone needs a workshop by standalone. I think it's a very specified field. So, shall we move forward?
Yeah.
Just one last online question from Chitra. Again, this is very broad, but are there any side effects in adjuvant analgesics?
Yeah, of course. Any side effect, name it, you have it. Sedation, renal impairment, even paracetamol has side effect. Everything has side effect. You have just to monitor. That's why from the first of the lecture, we're saying every day, regular assessment, individualize your plan of management, and you'll be in a safe place.
But if the question is it dangerous to have adjuvant treatments, the answer is no.
No, yeah. You have to.
Please.
you finished answering that one?
Yeah, we're done, Dr. Rekan.
I thought some clarifications are necessary about two other points brought up. First, no other analgesic other than paracetamol and morphine have the lowest side effect profile. Margin of safety is very good for morphine. Therefore, for initiation of therapy, very clearly for opioids, morphine is best. Up to 1/4 of patients with cancer pain will get resistant to morphine because of the metabolic pathway, which is believed to be morphine through morphine 3-glucuronide, so that high concentrations of morphine 3-glucuronide cause neurotoxicity. In such patients, methadone can be remarkably effective. But it is not something to be casually started. The margin of safety is low. You can kill somebody easily with methadone, because if the person has a QT interval abnormality, then it can be toxic. As already you have said, all the side effects, the interactions can be dangerous. So what I'm saying is, if somebody does not tolerate a slightly higher dose of morphine and has inadequate pain relief, they have to go to somebody with experience with methadone, and that can be remarkably effective. And of course, opioid substitution therapy for addiction, methadone is the opioid of choice. But again, that is to be done somebody with experience in its management. The other point is about ketamine. That has the narrowest margin of safety among all the medicines said so far. But again, for an occasional patient with opioid-resistant pain, it can be remarkably effective. But 3 important side effects we have to remember. We have to remember before we start ketamine therapy. The first is that it can cause significant dysphoria. And that's not an occasional patient. At some dose, everybody will go to have hallucinations. And notoriously, doctors have been incriminated for many crimes committed by the mind of the patient under ketamine. The second thing that was not well known at one point, but it's a recent knowledge, is that it can cause significant hepatic toxicity. So our routine is to every 3 days do hepatic enzymes. If we find the SGPT elevated, then we have to stop ketamine. And another minor but major issue is chemical vesicopathy. Again, not uncommon at all. Every day the patient on ketamine has to be asked, do you have burning micturition? The culture will be sterile. But the day he says he has burning micturition, it has to stop. Because even after you stop it, the dysuria can be very prolonged and can be really troublesome. Very useful medicines for some people, but to be taken seriously. Thank you.
Thank you, Dr. Jacobar, for your valuable experience and sharing your experience with us. So let's move on with this.
Let's go forward for the second case scenario. I'll present it, Dr. Hamadi. So we have Mrs. S. She's a 52-year-old lady with metastatic breast cancer to bones. She has been under the palliative care team for 6 months. She came to the clinic complaining of pain throughout the day, especially after specific activities such as showering and walking her dog. Her pain has been controlled for a good matter of time on fentanyl patch 50 mcg Q72 hours. However, this pain has been frequent for the last 4 weeks, and she describes it as tapping on her hips and lower back. It lasts for 14 to 30 minutes and occurs multiple times through the day. She has immediate release oxycodone, 5 milligrams PRN, and she is using it 4 to 5 times per day. So the key question is, what kind of pain does the patient is experiencing? What we call this kind of pain? Can just anyone shout it out loud?
Dr. Ala,
Yeah.
incidental or breakthrough
Fall
pain?
under the category of breakthrough pain. So what is breakthrough pain? Breakthrough pain refers as a transient pain exacerbation that can occur in a patient with stable and adequate controlled background pain. It can be incidental, it can be end-of-dose failure, and it can be uncontrolled, okay? So incidental pain is associated with specific activities or events such as that patient before as showering or walking her dog. End-of-dose failure is recurred toward the end of dosing interval for the regular scheduled medication. Uncontrolled persistent pain means that the patient has a background medication routine scheduled and still have breakthrough pain inside. How you will manage this breakthrough pain? Easy, simple. Short-acting medication. Always use short-acting. Give the patient advice before showering, before walking her dog. 30 minutes, take the short-acting medication. So, if it's available, as Dr. Neil mentioned before, check the availability of your medication. If you have the rapidly acting transmucosal fentanyl, it's a good choice for those patients. If the patient needed more than 3 breakthrough doses per day, please consider to titrate the regular background medication because it seems that it's not enough. Moving forward to the next case, number 3. So we have Mr. K is a 58-year-old gentleman diagnosed with late-stage metastatic lung cancer to the bone, spine, and ribs. This patient was transferred to palliative care services. He complained of severe pain in the lower back associated with tingling and burning sensation in his lower limbs. The patient stated that recently he has bursts of crying, difficulties falling asleep. He has some questions about the meaning of his life, fear of death. Mr. K is a father of 2 children and he is worried about impending death and unresolved conflict to the family. So please, everyone together, a multidisciplinary team, what is the challenges that we are facing in this patient? Can anyone elaborate? Psychosocial, yes. How you will, just in brief, how you will communicate with this patient, how you will explore his idea, his concern. Maybe he's having grief, right? Maybe he's having fear, maybe he's having spiritual questions. So, you have to explore his pain because this could make it worse. Severity, location, type, as we mentioned before, his plan, what is pain medication he's on, his psychosocial distress. Please involve all the multidisciplinary team together. Don't forget, sorry. Don't forget, explore the patient's fear. Sometimes if the patient has a big ego, he will not explore that he's afraid. He will say he's fine. Just explore his fear and just try to go through his ego. Validate his feelings. No judgment. Enroll him in the plan. He will feel safe if he was enrolled in the plan. Involve his beloved ones. Please, please mention the advanced care planning. Maybe it's new in our Arab culture, but it's crucial and it's important.
Just I want a small remark that these psychosocial distresses are interlinked with the pain. So when patients have social issues or emotional issues, his pain severity may be higher. And in the opposite also, when pain is not well controlled, this can increase the psychosocial distress in the patient.
So for this psychosocial challenges, don't forget, can we go through the next slide, please? Don't forget to use the complementary method. So ask the patient to have the mindfulness-based stress reduction, give him CBTs, breathing exercise, biofeedback, involve music therapy, aromatherapy, acupuncture, pace his energy. This is all worth it and it can work sometimes.
And in this specific case, patient was asking questions about the meaning of life or why me. Don't hesitate to involve the counselor or the spiritual care. So let's explore the opioid-related management challenges.
As Mr.
Just before you go ahead, we'll save some questions at the end. But I think it's important to say, especially in this part of the world where we get a lot of people from many, many different countries, the language that we use when we're assessing pain is very important.
Yes.
So I've been caught out many times asking somebody about pain. No, I don't have any pain, but they're clearly in discomfort. They're clearly uncomfortable. So we always have to be mindful that we should tailor our language according to the patient. So patients will use very different words from doctors.
And sometimes patient has the same language, but he has different background and culture. Even you have to pay attention for these details. So day by day, you will learn regarding the patient that you are facing.
Can I have... Oh.
So for this patient who's on stable pain management and they have psychosocial stress or crisis, and the pain goes up to the roof, and he presents to the emergency department. So what options we can give? I have a case who's not responding even to the IV opioids. So what options they can give to settle the pain, and then he can be seen by multidisciplinary team? Yeah.
This is an excellent question. In case of this patient present to the ER, and this is a common patient for all health practitioners or GPs and ER specialists, how to deal with this kind of patient. If he is in pain crisis, don't hesitate to see how was his total dose of morphine and give him, for example, doses subcut or IV to relieve him fast. And then next day, the multidisciplinary team and the palliative care team can be involved.
I saw a case, so emergency department giving, like, for example, anxiolytics, like, for example, IV diazepams, because the pain medication did not work.
As well, the benzodiazepine
I mean,
anxiolytics.
for this case, because there is psychosocial stress causing the pains go high. So after the giving the diazepam, the patient settled down.
Yes, excellent suggestion. Sometimes if we give them the benzodiazepines, they will be more comfortable. Please, Dr. Rafai.
Thank you. So I think my experience of total pain is actually a diagnosis in retrospect. So, you treat what looks like physical pain, you increase the opioids, you increase your adjuvants, your neuropathic agents, and it's when they're not responding to them, then you begin to think, what else is going on? So I think absolutely these patients may present to ED a number of times, not just once, or you see them on the ward round and they've had, 6 doses of your breakthrough analgesia. So it's only after you sort of have been seeing them for a little while, you go, what else is going on? Because not everyone is explicit in saying, I'm worried about my family. And they may not even have that insight into what is going on for them psychologically or spiritually. So for me, sometimes it is I'm quite far down the line of analgesics before I realize it's not just physical pain.
Excellent remark, Dr. Rafaiga. Sometimes also patients under palliative, we experience with them multiple admissions, and then we realize that there's something underneath this issue. It's not just about symptoms or physical pain. Sometimes they have social issues and they have problems. Any questions from the online?
So online, there were 2 more. Maybe we should deal with them before we go down this pathway. So one, I think, has been answered. Somebody was asking the best laxative for opioid-induced constipation. I think you already mentioned.
Stimulants and osmotic are the best. Avoid the bulk modeling and the softeners.
And a note on lactulose. Lactulose.
Go ahead. Sometimes with lactulose, the patients have they experience more gases and flatulence, and we prefer to give them something else. I had a question for you. How about docusate? How do you feel with what is your opinion regarding docusate?
So the evidence is not very good for docusate, but there are patients for whom it works very well. So it's being aware of the guidelines and the evidence, but also tailoring it, personalizing patient care. And then the last question, specifically about pharmacology of pain meds before we move on. Dr. Dina is asking, and again, these are extremely broad questions, what's better for pain management in the ICU setting, morphine or fentanyl?
Well, ICU is not palliative, so this is not our question.
They are more experts.
Okay, I think there will be. Do we have any anesthetists?
Internist.
Internist, there you go.
So I disagree with your comment. I'm a pediatric intensivist and pediatric palliative care physician. I think they marry beautifully. We do a lot of end-of-life care, and I think it's really important that we do it in a holistic perspective.
Yes.
Unfortunately, the majority of my colleagues look at it from a physical perspective only, because that's how they're trained, how medicine is how we are trained. We focus on the disease and the medicine and the physical symptoms and the treatments, but we forget about the social, emotional, spiritual aspects, which is so important, especially for the families who have their children in the ICU, because they're the ones who are going through all the grief and bereavement before the children actually pass away. In terms of the question that's asked by the person online, it really depends on the dose and how the patient's responding. We always and availability. Morphine pretty much is very available universally in most, not low-income countries, but high-income countries and middle-income countries. So you usually start there, and you just titrate up. It may also depend on your personal comfort. You can escalate, because as we've heard a number of times, there's no dose ceiling. However, you will find that people who are working in the ICU start to get uncomfortable when they get to 60, 80 mics per kg per hour. And then they'll switch to fentanyl and suddenly have no issues escalating the dose all the way up to 5 mics per kg per hour, which is significantly higher. It's equivalent at least 200 mics per kg per hour of morphine. When we do a conversion for the infusions, we do a conversion of 1 to 40, not 1 to 100. So.
Yes.
And I'll just make one comment. We often get patients transitioning from ICU back to the ward, which is where we come in. So if a patient is on a fentanyl infusion and they're on, 25 mics of fentanyl per hour infusion, the ICU guys will often put a fentanyl 25 strength patch on and transfer them to
and
the
do
ward.
the bridging, yes.
And do the bridging. And that's because of the route of absorption. A 25 microgram fentanyl patch is equivalent to a 25 microgram per hour IV infusion, so that's okay. The second thing to say is that all opioids are not the same. So, and again, maybe the other palliative care people will say that for people who have very complex pain, the pain is multifactorial. Fentanyl is nowhere near as good as morphine. This has been my experience for pain with, what's the worst pain we see in cancer? Pancreatic cancer pain. Really nasty pancreatic cancer pain, fentanyl simply doesn't cut it. I don't know what the mechanism is specifically, but these patients need morphine, oxy, hydromorphone, diamorphine if you have it preferably, but fentanyl is really not the drug of choice in these. We're saying these things because this is the venue, but we don't expect non-specialists to bear this burden on alone. Please pick up the phone, even if we don't work for your hospital, and ask for help. That's what we're here for.
Excellent.
Could I just make one comment slightly off this topic about total pain, which you were obviously covering just now, and thank you. And the comments about patients coming to emergency with extreme pain that doesn't seem to settle. Sometimes just the simple intervention of a doctor or nurse who's not necessarily specially trained in palliative care, sitting and listening to the patient, is adequate to settle the pain alongside the analgesics. So we talk a lot about the wider multidisciplinary team, the counsellors, the spiritual support, which aren't always available to us, and certainly in an emergency scenario very often aren't available. But don't forget the power of just sitting and listening and showing compassionate care to people who are distressed alongside the analgesics you're using. And I think that we can do that even in an emergency setting where everything's very chaotic around and perhaps the doctor pops in and out very quickly. If a nurse or someone else in that setting can just sit and be with the patient, then that might be enough.
Yeah, I agree. Regarding these kind of patients we face like every 1 week, my first goal to admit the patient and get him out of the emergency room. Let him be in our ward, to see familiar faces, to be in his comfort zone. Then we will start digging in the psychosocial aspects and total pain. It's hard, but it can be done in very long time. Not very, but it needs daily base follow-up and activity and multiple team member to follow the patient. But it's doable. But you have to do it in your setting. It cannot be in the ER. You cannot tell the patient, this is your new medication, go home. It's not feasible.
Dr. Anu?
Yeah, just one short comment. The importance of reassurance, physical touch, holding the hand. I know in local culture it may not be acceptable because male, female. Sometimes when patients don't want to be seen by a male physician, I get my nurse and I say, just be with them, hold their hand. That confidence that the medical professional is there to help, and that you are in control of the situation. You may not be, but you have to be the calming presence, and right. Just holding their hand or just gently stroking. We have lots of patients with cancer pain, just gently sort of touching or stroking their hand or whatever is really helpful.
And it shows that we are compassionate with them, and it can be done at any setting, in the ER, in the room, in the palliative care unit. It's not reserved to the palliative care unit, I agree. Please, Kim.
I think it was helpful a lot also with severe acute pain like the one in emergencies. I find sometimes like you go on, you do the usual round, you adjust medication, and then you leave and you come back the day after. I think like the patient feels abandoned. I work with physicians in Canada. They would stay at bedside, or they would say, like, I'm giving it to you now. I'm going to see my other patient and coming back in 45 minutes to assess the medication at peak action. It will keep doing this until the pain is under control, then move on, And so it's not like a round as usual until you have like a severe pain under control.
Yes, and this is a human touch. It's not reserved to Canada or elsewhere. It depends on the physician and his compassion. So, shall we?
Yeah. So briefly now, I'm going to talk about some other challenges regarding the management. Terminology we always fear of: addiction, tolerance, diversion, misuse, physical dependence, and pseudo-addiction. In our care is always the tolerance and the physical dependence. Just to clear it out, first, the addiction is the misuse of medication regardless the harmful effect, physiological, physical effect, and it's being used not for the proper reason. Tolerance, unlike that, it's common in palliative care, and it means that the medication has less effective due to lack of good dosing or good management. So if you increase the dose, the patient will be fine. Physical dependence can happen not only with opioid, it can happen with nicotine, it can happen with caffeine. It's when the body realizes that it's depending on this substance to function. It's crucial to cut down the medication or the caffeine or the nicotine abruptly. If you want to cut it down, do it gradually, or give the patient his medication if he was a cancer patient and he's in severe pain, just to overcome his symptoms, or divert his medications. Other terminology we're using, like the diversion and misuse. Diversion is the transfer of prescribed medication from person who is prescribed of. The misuse is inappropriate use of prescription drug, whether if it was intentional or not intentional. The pseudo-addiction is distress and seeking drug behaviors that can occur in a context of unrelieved pain. The behavior will subside when you have a good analgesic plan. And also sometimes we face this in our practice. Also, some challenges regarding the management is the hyperalgesia. What is hyperalgesia? It's a clinical phenomena defined as state of nociceptive sensitization caused by exposure to opioid and characterized by paradoxical response to pain, whereby patient receiving opioid could become more sensitive to pain. Reasonable approaches to manage this include reduction of the opioid or discontinuation or rotation. Use the multimodal analgesic and adjuvant therapies to overcome this phenomenon. So if you have a patient with pain and you are starting to treating him and you're following, but there is no result, you can have hint about poor pain prognostic factors. What are the poor pain prognostic factor? If the patient is complaining of neuropathic pain, if he has any cognitive impairment, if the patient has any addictive behaviors in the past, if the pain was incident, and if the patient was having psychological distress. So we will go through the total pain, the total suffering, and what we mentioned before. So
let's go to our last case scenario.
Yeah.
Mr. H is a 60 years old gentleman with advanced non-small cell lung cancer, with meds to the spine and his liver. He has been receiving palliative care for the past 3 months. Mr. H had severe back pain with shortness of breath. Initially, he was treated with oral morphine, but symptoms were not controlled. Medication were upgraded to morphine IV, continuous infusion, 250 milligrams over 24 hours, with 25 milligrams PRN dose Q1 hour. He's also known to have chronic kidney disease, which worsened recently with a eGFR level of 15 milliliters per minute. So, if we continue the interrogatory of the patient and his surrounding, we found that in the last 24 hours, his wife noticed that he became drowsy and confused. And he has been sleeping most of the time and waking briefly. And when he wakes, he appears disoriented and slurred in his speech. He also had several episodes of hallucinations and seeing things that does not exist. Appetite has been decreasing, and he is only receiving sips of water. In your opinion, what's happening with this patient, Dr. Ala? So these are signs of neurotoxicity induced by the opioids. So we'll go to examine him. Upon examination, you notice that the patient is lethargic with pinpoint pupils, exactly, and responds sluggishly to verbal stimuli. Respiratory rate is slow, around 7 per minute. Blood pressure is slightly low, and he was mildly dehydrated. So how will we approach this patient? So, as we mentioned, these are signs of opioid-induced neurotoxicity. So, how will you approach this patient?
So before
the signs.
Yeah, before you check for the signs, which is low respiratory rate, if there's any meiosis, confusion, increased somnolence, and level of consciousness. Before prescribing any opioid, put in mind that it could happen, but it's not that common. So if your patient is very thin, fragile, old, naive, please hydrate him. Give good hydration. Cut off the doses. Don't give full doses, just to monitor and see how is he responding. The interval, if it's Q4, just start with Q6. This is if the patient was fragile and old, and as I mentioned before. After that, let's say the toxicity happened. What you will do? Hydrate, rotate. In palliative care, we don't like to cut off the whole medication in once because the patient will have rebound pain and it will be very difficult to manage that. So what you will do, you will convert, you will reduct, you will watch and say, if you need naloxone, be my guest, start naloxone, and continue evaluation.
But it's rare in palliative care that we use naloxone. Studies show in the practice, if we reduce the doses, we give good hydration, we can pass this.
He can pass this event, yes.
And naloxone can be used sometimes like a diagnostic tool. If you are not sure about is this a neurotoxicity induced by the opioids or no, you can give one bolus of one shot, one single dose of naloxone, a small dose, half the dose. If he responds well, it means this is a neurotoxicity, just to confirm your diagnosis.
So we already had our questions. Does anyone has
additional questions?
Additional case or question to wrap this session off? Okay, thank you for listening.
Thank you for your attention.
Just I want to close with some home take messages, please. If you allow me, Dr. Hamadi. Just
we have time, Neil, for last.
Yeah, it's only two. So please, this is our take home messages. We'll wrap our workshop with. Effective pain management in palliative care starts through good assessment, physical, emotional, psychosocial factor that may contribute to pain. Please use the multimodal approach for pain control. Opioids are crucial for management in palliative care setting, but always consider going stepwise and cautious to continue re-evaluation. Pain management should be personalized and individualized. Anticipate and manage common side effects from opioid prescribing. And finally, holistic team is essential in palliative care pain management with ongoing communication between the patient, patient's family, and the team for the better outcome and symptom control.
Thank you very much for your attention.
Shall we carry straight on, or does anyone need a quick 5 minutes? Straight on? And then it's lunchtime. Okay. So I'm Katie Sweeting. I met most of you yesterday if you were here. I'm a palliative care consultant at Mediclinic Parkview Hospital in Dubai, previously at City Hospital in Dubai, and before that in the UK. And I share the stage with my colleague, Dr. Rasha. Well, I say colleague. We don't work together, but we're friends. So Dr. Rasha, I'd like to introduce.
Hi everyone, I'm Dr. Rasha Mustafa. I'm a palliative care specialist in Burjil Medical City, and I've been working in Burjil for almost 2 years now, 2.5, and have been in Taiwan before that for more than 10 years. So our session hopefully will be light, quick. After all this knowledge, what we got from you guys, thank you so much for this informative session. For our session, me and Katie would like to be more interactive approach. It will be very simple, quick cases, but we need your input with us. Thank you, and we are starting now. Yeah, I'll go. I think this is yours first.
Can't get the slide to move on. Sorry, technical hitch. Okay, so there are many, many symptoms that our patients can experience, physical, psychological, social, and spiritual, as we've discussed or has been presented to us several times in the last couple of days. But Dr. Rasha and I have chosen 2 physical symptoms to focus our short workshop on, which perhaps occur commonly and also in our experience perhaps cause some uncertainty for the healthcare professionals that are looking after the patients. So the first symptom that we've chosen to focus on is nausea and vomiting. I think in my experience, both in acute hospital medicine and in palliative care, different hospitals and cohorts of physicians have a kind of choice as to what antiemetic they will just routinely prescribe on a patient's drug chart. When I started medicine in the UK, every patient had metoclopramide prescribed on their drug chart for PRN use as an antiemetic. And then, perhaps in the last decade, every patient has ondansetron, Zofran, prescribed as the PRN antiemetic of choice, but that might not be my choice. So I thought I'd just start that with a little comment, and we'll focus on a case. Yes. So my patient, which perhaps would be someone that you can think of in your mind that you've come across and cared for as a 65-year-old man. He's got metastatic colon cancer, and the metastases are in the liver and the bone. And more recently, his disease has progressed. So he's having active treatment alongside palliative intervention. And because of disease progression, the oncologists have decided to switch his acute oncological treatment, so his chemo regime has recently changed. As is not uncommon, he doesn't only have cancer, he has a number of other medical conditions, hypertension, type 2 diabetes, and clinical depression, all of which he is taking medication to control. So they are all managed and controlled currently. And he presents to you in whatever clinical setting you work in with nausea and intermittent vomiting. So I've got 3 questions that I would like you, if possible, to just have a discussion about on your individual tables so that you're doing a little bit of the work for me. So the questions I want you to discuss with your colleagues, who might be other medical colleagues or not, so it doesn't matter if you don't come up with a gold standard answer. What are the possible causes for nausea and vomiting in this patient? How do we assess nausea and vomiting in a palliative care patient? And what options, other than Zofran, do we have to manage the nausea and vomiting? So I will just reverse the slide so you can see the case again, but if you can just think about those 3 questions, and then maybe someone from each table can interact with us and present some answers. I'll just give you a few minutes. Rasha and I will wander so that we're available to answer questions from you, and I look forward to hearing your model answers. So there's your case again.
You want to see the questions, the 3 questions? Or it's okay, it's clear? I think you need to put the slide back. Yeah. Yes. Anyone ready? Any table? Or you need more time? Or we should select randomly? Do you think?
Has everyone got their answers ready?
Yeah.
I feel like I'm doing medical student teaching. I'm sorry.
Yeah. We are looking for simple answers, by the way, not a full answer.
I'm having a direction to the back.
Okay. Yeah, someone was waving.
Hi, good afternoon. Yeah, for the number 1 question, what are the possible causes for nausea and vomiting in this patient? I guess it's the side effects of the medication he is taking and chemotherapy effects. And for number 2, the interaction with the patient to assess the symptoms in palliative care. And number 3, antiemetics are the options to manage nausea and vomiting.
Excellent.
Thank you.
Thank you. Any other thoughts about, so thank you, you're completely right, that we have to think about the chemotherapy being a contributing factor to the nausea and vomiting. Any other ideas or contributions as to what might be causing the nausea and vomiting in this patient? Yes, please. So the lady's saying bowel obstruction as a possible cause. Particularly given his diagnosis of colon cancer. Thank you. What else from his history could be causing? Yes.
It could be multiple causes. First, from the disease itself. Second, could be chemotherapy induced. Maybe it's not mentioned, but could be anticipatory nausea because of past experience with the chemotherapy. Could be systematic, as our colleague said, could be intestinal obstruction or any other cause, could be other medication. So I will check the other medication for the second question. I will check other medication, what are the medications the patient is taking. For the treatment, it will depend on the cause. There is no one single best answer. If it's chemotherapy, there is the triple antiemetic they take. If it's, for example, intestinal obstruction, we'll have to treat the cause and give adjuvant medication. So it will depend on the cause, and we have to look broadly. Not just because he's on chemotherapy, we will stick with the chemotherapy cause. We will search for other causes and then conclude the treatment upon it.
Thank you. A lovely contribution. And I like that you included anticipatory nausea in there. So the nausea that comes from perhaps fear or anticipation that the chemotherapy or something else is going to make you sick. Quite a lot of patients who get nausea when they've got a scan because they're really anxious about going in the scanner and what that might show. So just being aware of that psychological contribution to nausea is really important. And we might then target it with different medication. Any other causative?
Hello, my name is Dr. Bakar. I just wanted to add, because the patient is hypertensive, so uncontrolled blood pressure can also lead to nausea and vomiting. Plus, what you just said about depression, anxiety, that can be a leading cause. I agree with the rest of the explanation as well. That's my
Excellent. Any other thoughts on causes?
Thank you.
We've elicited quite a few, just from the discussion, that it might not be as simple as the first contributor very correctly said. It might be the chemotherapy, but there are so many other things that might be contributing. You have something at the back?
Hypercalcemia.
Excellent. So electrolytes need to be checked as well. My second question was about assessment of nausea. I think we've had some thoughts about what might be causing it and what we might treat the nausea and vomiting with. As you correctly said, probably depends on the cause. What about how do we assess, what questions are we going to ask the patient about nausea and vomiting? For pain, we have that really nice kind of schedule, don't we? I always use Socrates, but there are other models that people use to do a very thorough pain assessment. How about for nausea? What kind of additional questions do you want to know? Maybe the table. Here.
With or without meals, the nausea? This is before meals or after meals? And on an empty stomach?
Excellent. So association with food on an empty stomach. Any other questions people ask about nausea and vomiting?
More like ask about the primary causes, primary disease, sometimes gastric and malignancies more causing more nausea other than other type of cancer.
Okay, yeah, yes, so the type of disease people have. Okay. Any other comments or thoughts from the floor before I present a couple
Maybe
of slides?
some indirect questions regarding the food, what he has taken previously. Like, do you want to take a glass of milk? So maybe he will say no, because he had milk. I'm saying an example. So he had milk before, and then he don't want to take. Maybe that's the reason for his,
intolerance.
So indirect questions, I mean.
Brilliant. So maybe a particular type of food is causing it, or he associates a type of food with nausea. Again, a kind of anticipatory.
Yeah, then he'll say no, or very irritated answer for that, so we can understand maybe that is also causing that. It's a common man's view. It's not from the...
Excellent. Any other thoughts, comments?
Just a thought, obviously, if we're worried about bowel obstruction, we need to consider whether it's bilious or not, and the quantity, and whether it's causing dehydration in terms of the severity of the vomiting. If it's gotten to the point, whether it started with blood or it's become bloody, that's obviously very important to know as well.
Yeah, so he's nauseated but also vomiting, so knowing what the vomit is and looks like, maybe it's coffee ground, maybe it's, as you say, bilious, hematemesis, all sorts of different things can help just hone in on the answer.
Also, because he's having metastatic disease, so maybe there's sinus, like increasing intracranial pressure. Yeah. It's like brain mets.
Yes. Yeah. So raised intracranial pressure for people who might not have heard that. Okay. I will go back to the stage. Excellent. So just a very few brief slides to summarize pretty much what we've covered anyway from the contributions from the floor. So nausea is a subjective sensation. So whereas vomiting is actually something that you can visibly witness occurring for your patients when a forceful expulsion of the stomach contents occurs. Nausea is caused by stimulation, by noxious stimuli in receptors in various sites, so the gastrointestinal tract, the vestibular system, the chemoreceptor trigger zone, and the higher CNS center. Whereas vomiting occurs because of stimulation of the vomiting center by one or more of these nausea receptor zones. And I have hopefully, a diagram to illustrate that. I always think it looks really, really complicated, but it demonstrates that there are several different sites in the brain that contribute to either singly or together to nausea and then to vomiting. And the reason that I find this diagrammatic representation really helpful is because it helps, once you've elicited the cause, to also direct where you might want to block receptors, and so which drugs or otherwise you might use to control the nausea and vomiting. So I'll just let you have a brief look at that one. I hope it projects okay. And these are all the different causes of nausea and vomiting, many of which might apply in the case that I presented to you. So if you look at the side effects of drugs, almost every drug will list nausea as a side effect. Some more commonly, some less commonly, but nausea comes up on almost all the side effects for all drugs. But drugs that our patients are on that very commonly cause nausea include antibiotics, anticonvulsants, opioids, as we've already covered in the first session, chemotherapy, non-steroidal anti-inflammatories, SSRIs, and people with substance abuse or misuse. Someone, I think it was Dr. Neil, mentioned hypercalcemia, so that would be what I would term a metabolic cause of nausea, and that also includes liver failure. So many of our patients have got deranged liver function, not truly in acute liver failure, but deranged liver function, and that can contribute to nausea. Renal impairment, renal failure, hypercalcemia, hyponatremia, and ketoacidosis. Lots of our patients present with nausea. The hypercalcemia presents as nausea, and we perhaps attribute it to other reasons. They've had chemo, or they're on opioids, or it's part of their general fatigue and frailty that they also feel a bit sick as well. And it isn't until we check their electrolytes, including calcium, that we discover that actually there's a potential reversal cause for their nausea. Visceral causes of nausea include bowel obstruction, as we've already discussed, gastroparesis, hepatomegaly, cholecystitis, pancreatitis, malignancy, most commonly malignancies in the GI tract, but malignancies in other places can have a paraneoplastic effect that causes nausea for patients, and abdominal ascites. CNS would include your raised intracranial pressure, which might be due to metastases, but other causes also. Sometimes that nausea that doesn't seem to respond to any medication, it might be a signal that they've got meningeal infiltration by the tumour, and also vestibular causes. And then we've got the kind of anxiety-related nausea. So maybe anxiety about treatment, disease-related anxiety, anxiety that's caused by all sorts of other causes. And pain per se can cause nausea. We all know that from our own experience, our personal experience of perhaps having acute pain, that we sometimes feel quite sick because of pain. So my suggestion for assessing any symptom in palliative care is to use a very similar kind of formula of questions. So you want to know the severity, frequency, and duration of the symptom, exacerbating and relieving factors, associated symptoms, and then really importantly in palliative care, what worries the patient most about these symptoms? So what might you be able to reassure them about, or what impact is the symptom having on their daily life? And you can use this series of questions for any symptom that a patient comes to you with, and it helps to guide your management, but also helps to give some reassurance and to kind of elicit some of the other more holistic aspects of the symptom that the patient is bringing to you. And again, my management plan would always start with checking for reversible causes, which is why we've gone through all these potential causes. We might be able to treat some of them. We might be able to adjust their medication if it's due to that. They might need to have hydration, or they might need to have electrolytes corrected. Maybe this man's diabetes control needs to be reviewed by a diabetologist or other. Maybe the chemotherapy regime needs to be looked at. So what are the reversible causes in your patient for their symptom, in this case for their nausea? Secondly, before we move on to drugs, what sort of supportive or non-medical interventions can you make? So for patients, often in the hospital setting, just the smell of the food arriving can be enough to trigger an episode of nausea. Is there a way that can be managed? Or in their own home, can the kitchen door be closed, or can they be closed away from it so they don't get stimulated by the smells of food? Loose clothing can be helpful for some. Adjusting how they eat. So people are very fixed on eating 3 meals a day because it's what they've always done. And I frequently tell my patients, for all sorts of different reasons, not just for nausea, but actually you're better to divide your meal into smaller, regular portions that your stomach can tolerate. And perhaps that will control the nausea, just dividing the total amount of calories into 6 rather than 3. Avoiding caffeine and alcohol, regular mouth care, psycho-emotional measures such as relaxation, mindfulness, CBD, perhaps psychotherapy. And then complementary therapies. Some of these are not evidence-based, but some patients find relief from Reiki and acupuncture for nausea. There's some evidence that focusing on a particular acupuncture point can help some people. And you've probably seen these pressure bands or maybe use them yourself. For some of our patients, they're not enough, but they might together with medication, just help to relieve the symptom. And then we have antiemetics. So other than metoclopramide and ondansetron, what antiemetics do we have in our armory that we might use?
Aprepitant. For chemotherapy induced.
Yeah, any others? Haloperidol, someone says?
Yes,
You said haloperidol, thank you. It's interesting that cyclizine doesn't come up. We don't have cyclizine readily available, but cyclizine is a very commonly used antiemetic. But so I hope this project's okay. It really is to demonstrate there are quite a lot of different antiemetics available, and that you should try to match the antiemetic to the cause of the nausea and vomiting that you've elicited. So, for example, if it's a vestibular problem, then antihistamines might be effective, or antimuscarinics. For post-op nausea or motion sickness, or even for not complete bowel obstruction, but subacute bowel obstruction, sometimes a dopamine antagonist, such as metoclopramide or domperidone. Chemotherapy-induced nausea and vomiting or raised intracranial pressure respond to higher dose corticosteroids, dexamethasone. Lots of patients receive dexamethasone as part of their chemotherapy induction therapy for the nausea. Radiotherapy and chemo-induced nausea and vomiting, abdominally caused nausea and vomiting often respond well to 5-HT3 antagonists, so that's drugs like ondansetron. And again, not so recently now, I used to say more recently, but actually they've been around for a while, neurokinin and antagonists, so that's uriprepitant, good for post-op nausea and licensed for chemotherapy-induced nausea and vomiting. Oh, I remembered them all, but they're all there for you, the names of some of those. So that is the end of my sort of formal presentation about nausea and vomiting. Are there any questions before I hand over to my colleague for a short workshop on shortness and breath? Any other questions about nausea and vomiting? Anything online, Dr. Neil? Oh, thanks. Dr. Pfeiffer?
It's not a question. It's more what Neil was saying earlier about the language that I'm just very aware of. So if I use the word, do you feel sick? A number of patients from certain communities use the word sick to feeling, to relate it to just feeling unwell. So I think I've just learned over the years to be really specific about what I mean by sick or vomiting, or, you know, it's just saying, do you feel sick? A lot of people will say, they'll understand that as, yeah, I just feel really unwell.
Yeah, no, thank you. I think it's language and communication are sort of so important, aren't they, in all aspects of what we do in healthcare. But understanding what the patient means by what they're telling you is important. And actually, with you saying that, a lot of patients are actually expectorating, coughing up sputum from the lungs, but they say that they're vomiting, but actually it's a completely different issue. So kind of honing in on exactly what they mean and what is going on is quite important before you go down the road of prescribing drugs for, perhaps the wrong indication. Thank you. Any other thoughts or questions? At the end of the whole workshop, we'll have an opportunity for other questions. So if you do think of anything related to nausea and vomiting, I'm happy to answer it in a little while. I will hand over to Dr. Rasha.
Okay. So I will take you through a very quick workshop or interactive session, and I know that people want to go for lunch break now. So I will start. My case is about breathlessness in palliative care. We won't be talking about much medications, but it's more of approach and interaction with the patients. So my case is a 41-year-old lady. She's married, having 4 kids, and she, apart from being a mother, she's very active, owning her own, running her own business. And she was diagnosed with breast cancer, but she took it very easy. She was coming regularly for her chemotherapy sessions, and it took her 2 years, unfortunately, but she started to progress. But the changes happened when she started to progress, because she was skipping in between her chemotherapy and follow-ups in the clinic. She came one time to our palliative care clinic where she's complaining of severe headache. We called our oncology colleagues and we asked them if she can be admitted and had proper investigations, because there is a high suspicion of brain metastasis. Unfortunately, during admission, we found that this lady was very breathless, and instead of doing CT and MRI for the brain only, we did a whole body CT, chest, abdomen, and pelvis, and to manage, because she was complaining, not only, she was struggling and suffering with breathlessness and severe shortness of breath at that point. So yes, she was admitted. The CT and MRI for the brain were done, and we decided, or we planned her for radiotherapy, but we need to manage also her shortness of breath, which she never mentioned or complained of, because she was using herbal remedies at home, cough syrups and stuff, in order to be with her kids and continuing her normal life. So now, yes, I'm not going to focus on her radiotherapy and the main issue of admission. I would like to focus on the breathlessness. How can we approach that? How can we assess her shortness of breath? Any? Yes, please. Yes.
Hi, so she's a cancer patient. So
Yes.
first thing for shortness of breath is PE, rule out if she has a PE.
Yeah.
And the other would be pneumonia, because she has a dry cough, generalized body pain.
Correct.
Heart issues as well that can cause shortness of breath, or obviously if there is a met causing in lungs that's causing shortness of breath for her.
Excellent. I can't see the resident here, but yes, this is the approach. We have to go systemic. This is what the differential which we are thinking about. So first thing first, we have to do labs and CT scans. She was not febrile, and labs including WBCs, CRP and procalcitonin were all normal. So she was not septic at that point. But this was her chest X-ray, unfortunately. So what do you think without reading the comments? Without reading the comments, please, what do you think? I think it's my mistake. I should have kept it away. Any suggestion? Doctors? Doctors? Lymphangitis. Unfortunately, the saddest part is that she was having lymphangitis carcinomatosis. So yes, we can see the secondaries and few cannonballs here. very minimal pleural effusion on the right side, but we were really concerned with this X-ray because 3 months back, everything was clear and normal. So we had to go for the CT scan. And it's very clear of lymphangitis carcinomatosis. For us as physicians, we know this is one of the worst complications patients can have with cancer, because when they have pleural metastasis and pleural effusion, it much be easier to be managed. Even the highest risk PE still can be managed with heparin, but when it comes to lymphangitis carcinomatosis, it's really challenging, and you can't approach it only with medication or one line of medications. So now, how can we manage this patient's symptoms? I think people are hungry now. I will go quickly because, yes. First thing first, for lymphangitis, the only thing which can really help to some extent, it will not cure it, it's the steroid, the golden drug. What else, apart from steroids? We can make it easy, like we will divide it pharmacological and non-pharmacological. So what non-pharmacological approach we can use in this patient? Simple things. Portable fans, keep the aeration of the room, will help them feel more relaxed and they will not require oxygen. Then if we go to oxygen, yes, we can start with nasal cannula, face mask, and even going higher non-breather and the stuff. But someone is, yeah please.
Propped up position for the patient.
Yes.
And fan in front of the face so that the patient feels that negative, the positive pressure ventilation.
Excellent.
Room should be airy, and the patient's bed can be near the window or somewhere he can feel good. Oxygen support can be there. And I've seen in patients, if we give oral morphine, it really helps the patient in a BD dose if we give. And a propped up position, it really helps the patient. Excellent. And also the patient can slowly breathe out, like he can inhale the air and then slowly breathing out. So that's pursed lips and blowing out, so the exchange of air and oxygen takes place much better.
Yes, perfect. And you are right in this, when you mentioned this point of using the morphine, low-dose morphine is indicated as per the guidelines, and it's equivalent or even better to using oxygen. So, yes, what else? One simple thing missed. Bronchodilators sometimes can help with that shortness of breath. So, I have to apologize, my slide is very crowded and my intention was not to read from the slide, but this is the NCCN guidelines of managing dyspnea in cancer patients. So first we will assess the patient and comprehensively and make sure that we're not missing anything. So if there is reversible causes like pleural effusion, we can drain it. If pneumonia also can be treated. Then we will go for, after draining, or if possible to drain, then we'll go to the next step. And especially with the lymphangitis cases, we will start with steroids, as we said. If there is any, and as per the guidelines in general, not specific for our case, but if there is metastasis where there is a clear blockage, we can go for radiotherapy to help shrinking the tumors. And finally, we can go for oxygen therapy. But with oxygen therapy, I would like to just mention that we have to be cautious with using oxygen. I know that all physicians are very generous with using oxygen and, as supportive as non-pharmacological support to the patient. But the thing is that when we put patient on nasal cannulas or face mask, we keep them confined to the rooms. Most of the patients who needs oxygen, they feel air hunger. They can be treated only simply by put them in an area with well-ventilated area, or just put a fan in front of them. And this will keep them mobilized rather than just connected to multiple tubes. And then, as I told you guys, we can use bronchodilators. Not all bronchodilators are indicated, especially in the case of lymphangitis, canceromatosis. I don't recommend going, or we don't recommend going with the salbutamol because of the tachycardia and the other side effects with the patients. But we use antimuscarinic and atrovent, and we can see some good response with that. Finally, I want your opinion about the use of non-invasive ventilation, and I need the doctor's experience, please. What do you think about using non-invasive ventilation for patients with advanced cancer? I think this is the debatable question, but I really like to hear from you guys. Dr. Afai, you want to say something? I can see. I will close with this, but I really want the input from doctors.
So I struggle with it. Being new from the UK, it's not something that we do very often.
Yes.
And I think if we are going to do it as a supportive measure, because of course patients with COPD are very likely to have lung cancer, they may need to be supported in other ways. But I think with any treatment, whether it's feeding, hydration, non-invasive ventilation, I think you've got to have the parameter of what are you looking for.
Yes, yes.
What is your sign of improvement? What is your what improvement are you looking for that if you don't, and what's your timeline?
Yes. Most importantly, we have to explain this clearly to the patient and their families, because it's not an easy decision to make, and we shouldn't we shouldn't give them high expectations with using the non-invasive ventilation. I will stop at this level because we don't really recommend going for ventilation or tracheostomy tubes in our patient population.
And can I make a comment?
Yes.
Sorry.
Yes, please.
I've started seeing high flow oxygen being used much more commonly. I'm not an expert by any means, but it seems to be very well tolerated by the patients, and they almost don't seem to think that it's more than having oxygen. So I've seen that being used more in the hospital. And I guess my reservation about non-invasive ventilation or high flow oxygen is it can only be given at the moment in this country in a hospital setting, and in my hospital only in the ICU. And so it does mean that the patient is stuck in an ICU setting. And the other comment I have about breathlessness and oxygen use generally is there's quite a tendency, especially for families, to monitor patients' SATs continuously.
Yes.
So even for my patients at home, the family often have a pulse oximeter, and when the SATs, they've been told, the SATs must stay over 95 or whatever number they've been given, and as soon as it drops, they call an ambulance and bring them into hospital. And so I understand the desire of the family to monitor the patients, but I think as healthcare professionals, we perhaps should start that conversation before they leave the hospital about the value of monitoring SATs, blood pressures, whatever it happens to be, if we're not going to act on whatever the number says. So for example, in the ward setting, if someone's dying and their SATs are dropping, and the family are getting distressed and the patient's not going to go to ICU, what is the value in watching those SATs drop for our patients? We need to kind of shift away from being so medicalised. And particularly in the home setting, I think it can cause a huge amount of discomfort for our relatives looking after their loved ones at home.
And yes, you're right, Doctor. Many times with lots of counseling to the patients and families, we can convince them that using low-dose opioids might be much better than going for this high oxygen, especially non-invasive ventilation, because it's really compromised the quality of life for the patients.
Absolutely, and the problem we have with people doing, and unfortunately there's a lot of self-treatment. I have seen people cranking up oxygen on their relatives, which is dangerous because we can have type 2 respiratory failure. So over-medicalizing things is bad, and in the UK we used to take people off monitors when they're reaching the end of life, because it is distressing to see the oxygen sats or the heart rate coming down, and you're really not achieving anything by having those monitoring. It's just good, like we had the palliative rounding every 1 hour or 2 hours, depending on the institution where you are. So those things are much better, I think. Thank you.
Yeah, in my practice, we have to keep educating them daily, as you said. Like, we are not treating the machine, we're not treating the monitors, we are treating the patients. And it's not every time you have to achieve the high oxygen because it might be harmful. And we have to tell them that oxygen is a drug. Because people are thinking that oxygen is the air and it's normal and you have to have it 100% or at least 99%. So every day you have to keep educating them about your goals. And the target is the patient being comfortable, not the monitor.
And I don't know whether we have a session on medical ethics and
We
the
need.
interaction between family and doctors, because
need, yeah.
great, we'll talk more about that
We
then.
need that,
Yeah.
Thank you very much. And I think now we are free to go for lunch.
Thank you, everyone.
Yes. Thank you.
Excuse me, we asked Dr. Katie and Dr. Rasha to come on the stage for the award, and Dr. Sana as well, and Dr. Ahmedi, and Dr. Neil. صاروا عم بيتغدوا.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year